Despite all the incredible advancements in modern medicine, burn injury remains one of the most complex and frankly devastating forms of trauma a person can experience.
Hmm.
We're talking about high rates of illness, significant risk of death, and truly staggering costs, especially when we look at the intricate cases or those complicated by a concurrent inhalation injury. It's a persistent challenge in critical care.
That's precisely right. Thermal burns don't just damage tissue, they unleash this, well, cascade of physiological responses that
Wow.
challenge every system in the body. And they can lead to profound long-term issues. And even with decades of progress in burn care, we still see significant room for improvement in outcomes, particularly for, larger or more complex injuries.
Okay, let's unpack this. Today on the deep dive, we are going to focus squarely on one very specific adjunctive therapy in this challenging landscape. Adjunctive hyperbaric oxygen therapy in the treatment of thermal burns. We're exploring if and how it might, maybe, move the needle on those stubborn statistics and improve patient journeys.
And our deep dive today is going to be exclusively based on a comprehensive review chapter. It's titled Adjunctive Hyperbaric Oxygen in the Treatment of Thermal Burns. The authors are Paul Cianci, Doctor of Medicine, Fellow of the American College of Physicians, Fellow of the Undersea and Hyperbaric Medicine Society. He's the corresponding author, along with Ronald M. Sato, Doctor of Medicine, and Julia Faulkner. So we are drawing solely from the information presented within the pages of this specific source.
Right, and this chapter is presented as a deep look into this topic, pulling together experimental evidence from animal studies, clinical experience from human trials and case series, the proposed mechanisms of how hyperbaric oxygen might actually work at a cellular and systemic level, and practical management considerations for, well, integrating this therapy into burn care.
Exactly. It references a significant body of work spanning several decades, which gives us a long view of the research in this field.
Okay, so our mission with this deep dive is to take that specific body of knowledge presented in this single source and thoroughly unpack it for you, our listener, a specialist clinician. We want to understand the evidence that this chapter puts forward supporting the use of hyperbaric oxygen, how it is proposed to work down at the fundamental biological level, and what its reported impact is on the critical outcomes that matter in burn care. Patient survival, length of hospital stay, cost of care, and the various complications patients face. All strictly as presented within the pages of this chapter by these authors.
So prepare for a detailed exploration drawn entirely from this source.
Right. Our high-level roadmap for this deep dive will first ground us in the latest background statistics on burn injury. Then we'll really delve into the complex pathophysiology of a burn wound and the systemic response it triggers. From there, we'll examine the extensive experimental evidence that has accumulated over the years, followed by the human clinical experience reported in various studies and series.
We'll discuss the proposed mechanisms of action, get into the practical aspects of clinical management, patient selection, and even touch on the economic factors presented.
And finally, we'll look at how the authors believe this therapy fits into the current philosophy of burn care and future research priorities, concluding with specific treatment guidelines and caveats outlined in the chapter.
All right, let's start by setting the stage with the background. We'll draw from the latest statistics presented in the American Burn Association Injury Summary Report for 2022. And it's worth noting that, according to the source, not much has actually changed since the 2016 report.
Okay, so what are the key numbers that jump out from that data that illustrate the ongoing challenge of burn injury?
Well, the overall mortality rate reported from 2016 through 2021 was 3.2%. Now, while that number might sound modest on its own, it represents a significant loss of life. And this rate isn't uniform. It varies dramatically with patient characteristics and injury severity.
How does that mortality rate break down by age and the size of the burn, measured as total body surface area?
Okay, so mortality rates clearly increase substantially with both advancing age and the increasing size of the burn. For individuals under the age of 16, the mortality rate was less than 1%. But this increases significantly with age, reaching up to 10% in patients aged 70 years and older.
Wow.
Similarly, for smaller burns, under 10% total body surface area, the mortality rate was low at 0.8%. But for very large burns, covering 70% total body surface area or greater, the mortality just soared to over 60%. So you can see age and size are major factors influencing survival.
Definitely. What about the difference in mortality between genders over that study period?
The report indicates that mortality rates among men and women showed some variation over the specific study period from 2016 to 2021. But when you look at the overall picture across those years, they're actually quite similar and remain pretty stable throughout the study timeframe for both genders.
the presence of inhalation injury seems particularly impactful. How does that affect mortality rates?
Oh, this is a critical distinction. It profoundly impacts outcomes. The mortality rates differed significantly based on whether concurrent inhalation injury was present. During the study period, the highest mortality was observed in patients with cutaneous burns combined with inhalation injury that was 26.2%.
26%.
Yes, this was followed by inhalation injury alone, which had a mortality rate of 8.3%. And the lowest mortality rate was for cutaneous burns alone at just 1.8%. So the impact of combined injury, where the patient suffers both skin burns and smoke inhalation damage, is clearly substantial here, driving up mortality significantly.
The source also mentions BIF scores as a way to predict mortality. Can you explain that concept and how the report links it to mortality?
Yeah, the BOE score is a simple calculation, really. It combines the patient's age in years and the percentage of total body surface area burned. And as you'd expect, the mortality rates increased steadily as BOE scores rose. For cutaneous burns specifically, without associated inhalation injury, mortality rates saw a noticeable increase, particularly with BOE scores of 70 and greater. They range from less than 1% for patients with BOE scores under 60 to nearly 85% for those with BOE scores of 140 or greater.
85%.
Exactly. And it's important to note that mortality was consistently higher for patients with inhalation injury, regardless of whether they also had associated cutaneous burns. It just reinforces the severe impact of inhalation injury. The source also points out a specific difference in mortality based on gender within higher BOE scores, noting that mortality was higher among men versus women when BOE scores were 110 and higher.
Okay, shifting gears from mortality to the length of hospital stay, what does the report tell us about how long patients are hospitalized for burn care?
Well, the average length of stay for male burn patients has remained quite stable over time, averaging about 8.7 days. But, similar to mortality, the length of stay is significantly impacted by the presence of inhalation injury. For patients with cutaneous burns combined with inhalation injury, the average stay was 21.3 days.
Much longer.
Significantly longer compared to those with only cutaneous burns at 7.9 days, or only inhalation injury at 6.8 days. This again just highlights the added complexity and, well, resource utilization associated with inhalation injury.
And how does length of stay correlate with BOE scores that combine age and total body surface area measure?
Length of stay generally increased with higher BOE scores, which makes sense.
Yeah.
But interestingly, it began to drop with BOE scores of 110 or greater.
Why is that?
Well, it isn't because patients with higher scores are recovering faster, unfortunately. It's primarily due to the dramatically increased mortality in this group, meaning fewer patients with very high BOE scores survive long enough to accumulate extended hospital stays. The report also noted a difference in length of stay based on gender at certain BOE scores, stating that length of stay was longer for men than for women with BOE scores of 90 or over.
Where are patients typically discharged after they leave the burn center?
The majority of patients, about 75.1%, were discharged directly home without requiring formal home health services. Another 7.4% were discharged home, but with home health services in place, indicating a need for some continued support.
Okay.
And of the remaining discharged patients, 8.7% were transferred to another type of facility, like a skilled nursing facility or a rehabilitation center, indicating a need for ongoing care beyond the acute hospital setting. The remaining percentages would account for, transfers to other acute care hospitals, deaths, or other outcomes.
Okay, so let's do a quick micro recap of this background section.
Sure.
We've seen that despite overall advancements, mortality remains a significant concern, heavily influenced by age, burn size as measured by total body surface area, and especially the presence of concurrent inhalation injury.
Which dramatically increases both mortality and length of stay.
Exactly. BOE scores provide a useful combined predictor for mortality and length of stay, although that relationship with length of stay changes at very high scores because of the increased mortality in that group.
Right.
And while most patients eventually go home, a notable percentage require transfer to other facilities for continued care, underscoring the lasting impact of these injuries.
It's fascinating here how clearly these statistics lay bare the persistent challenges in burn care, particularly for larger or more complex injuries or those with inhalation involvement. It really highlights the need for therapies that can improve these outcomes.
Moving on to the economic considerations, the source points out that burn care is extraordinarily expensive. How is that cost generally covered, and what does that mean for burn centers?
Well, the recent analysis from the American Burn Association Injury Summary Report 2022 detailed the payment sources. Medicaid was identified as the primary payer in 29.3% of cases, followed closely by commercial insurance at 25.7%. Medicare, self-pay, or the uninsured collectively accounted for another 11.2%, and workers' compensation covered 6.4%. The source asserts that this specific breakdown, with such a significant reliance on government payers, places a huge strain on the financial maintenance and, well, sustainability of burn centers.
It seems intuitive that longer hospital stays would mean higher costs. Does the source provide specific data on this relationship?
Yes, it highlights a clear and impactful relationship between length of stay for survivors and the size of the burn. The finding is that for survivors, the length of stay is slightly greater than 1 day % of total body surface area burned.
Wow.
This relationship means that even small increases in total body surface area can add significantly to hospitalization duration and consequently cost.
And the cost itself, can we put some specific numbers to that financial burden based on the source?
We can. The source provides specific average charges for different burn sizes, corrected to reflect 2023 inflation to make them comparable to current cost. And these numbers are quite striking. For survivors with total body surface area burns of less than 20%, the average charges were $323,443 United States dollars.
$300,000.
For less than 20% burns. For non-survivors with similar size burns, the charges were even higher, averaging $427,530 United States dollars. That indicates the significant resources consumed even when the patient doesn't survive the initial injury.
Right.
For larger burns, the costs escalate dramatically.
Yeah.
A 50 to 59% total body surface area burn averaged $1,338,886 United States dollars in charges.
Over $1 million.
And for a 60 to 70% total body surface area burn, the average charges were $1,466,655 United States dollars. The source explicitly reinforces that length of stay is the single most important factor driving the overall cost of care for burn injuries.
Okay.
Therefore, any therapy that can reduce length of stay has the potential for significant economic impact.
So a quick micro recap on the economic considerations.
Okay.
Burn care is undeniably expensive, with a varied payment landscape that strains burn center finances. Costs are strongly tied to length of stay, which in turn correlates with burn size measured by total body surface area.
Right.
The provided average charges for different burn sizes illustrate the immense financial burden, particularly for extensive injuries, making cost-effectiveness of therapies a critical consideration.
That certainly paints a stark picture of the resources involved.
Beyond the raw numbers and costs, what are the significant morbidities associated with burn injury, and what are the primary goals of burn therapy as outlined in the source, especially in the face of these complications?
Well, burn injury carries significant morbidity, leading to numerous complications that frequently add to mortality and prolong recovery. The most frequently reported complications listed in the source, which often contribute to worse outcomes, are things like pneumonia, cellulitis, respiratory failure, urinary tract infection, wound infection, and sepsis. These infections and organ failures are critical challenges in managing these patients successfully.
So in the face of these complex challenges and potential complications, what are we broadly trying to achieve with our treatment strategies?
The source lists several key goals for burn therapy aimed at mitigating the injury and its systemic effects. These include the prevention of burn shock, minimizing edema formation, preserving marginally viable tissue within the zone of stasis, that's that area surrounding the deepest part of the burn that's at risk of progression.
Right, the salvageable zone.
Exactly. Protecting the microvasculature, preserving mitochondrial function and the production of adenosine triphosphate, dampening the innate immune response, enhancing the host defenses, and providing the essential substrates necessary to maintain tissue viability and support healing.
And what about the ultimate long-term outcomes we're aiming for these patients?
The ultimate goals of burn therapy extend well beyond initial stabilization and wound closure. They include achieving patient survival, obviously, but also achieving rapid wound healing to minimize complications. Minimizing scarring or abnormal pigmentation for functional and cosmetic outcomes, preventing significant long-term problems such as chronic pain and major psychological issues, and achieving cost-effectiveness in care. The optimal outcome, the target we strive for, as the source states, is obviously restoration, as nearly as possible, to the patient's pre-burn quality of life.
Makes sense.
The source also references Wolf and colleagues, who summarized key problems and research priorities for the coming decade in burns, highlighting areas where progress is still urgently needed. A major and continuing clinical problem identified is the innate inflammatory response. This response is described as being induced by genetic factors and is characterized by a massive increase in cells like neutrophils and macrophages, while the adaptive T-cell responses are downregulated.
Downregulated T cells.
Right. And the source notes that these downregulated adaptive immune responses are likely responsible for late effects seen in severe burns, such as susceptibility to viral and fungal infections, which are increasingly problematic.
And this is where the source begins to introduce hyperbaric oxygen's potential role in addressing these specific problems, right?
Exactly. The source states that hyperbaric oxygen has been shown to modulate white cell adherence to the endothelium and to be helpful in the initial stages of inflammation, thus potentially preventing a prolonged and damaging hypermetabolic state. This modulation of the inflammatory response is presented as an area of fruitful investigation and a potential mechanism by which hyperbaric oxygen could improve outcomes. In fact, the burn injury itself is even suggested by some, as noted in the source, as potentially being the universal trauma model.
Interesting.
Implying that understanding the systemic response to burns could provide insights into trauma responses more broadly.
That's an interesting and potentially impactful concept.
Indeed. Wolf and colleagues also point out that controlling the hypermetabolic response and the massive inflammation is crucial for improving burn care outcomes. The source notes that despite the advances brought by early excision in accelerating healing time, the field appears to have somewhat plateaued in this regard. The authors suggest it is time to revisit whether healing times can be further accelerated, pointing to this as another area where adjunctive hyperbaric oxygen might offer benefit, building on earlier research that suggested improved healing rates.
Right.
Finally, Wolf et al. Identified the continuing problem of pain, both acute and chronic, as a priority for future investigation in burn therapy. Neuropathic pain, in particular, which is pain caused by damage to nerves, is typically difficult to treat, and is thought to occur in a significant percentage of those suffering severe burns, impacting long-term quality of life. The source notes that this specific challenge of pain is addressed later in the chapter in the context of hyperbaric oxygen.
Okay, another micro recap then on morbidity and therapy goals.
Let's do it.
Burn injury is fraught with complications, particularly infections and organ failure that increase mortality. The goals of therapy are multifaceted, focusing on initial stabilization, tissue preservation, dampening harmful systemic responses like edema and inflammation, and enhancing healing and host defenses.
Right, and key ongoing challenges highlighted by experts include controlling that pervasive, innate inflammatory response, accelerating healing beyond the current plateau, and effectively managing pain, especially neuropathic pain.
And hyperbaric oxygen is introduced here as a potential modulator of initial inflammation and white cell adherence, suggesting it could help prevent prolonged hypermetabolism and potentially accelerate healing, thus addressing some of these critical challenges.
Exactly.
Let's really delve into the science behind what happens in a major burn. The source describes the complex pathophysiology or the disordered physiological processes in detail.
Yes, the physiological responses to a major burn are significant and involve multiple systems. Immediately following injury, there's typically an initial fall in arterial pressure, followed by tachycardia, and a progressive decrease in cardiac output and stroke volume. This constellation of hemodynamic changes, if not aggressively managed with fluid resuscitation, is collectively referred to as burn shock.
And what happens at the metabolic and cellular levels throughout the body?
Metabolic responses are quite complex and widespread. They involve systemic metabolic acidosis and hyperventilation. At the cellular level, there's a crucial fall in adenosine triphosphate levels. That's the primary energy currency of cells, right?
Right, ATP.
Exactly, adenosine triphosphate. This is accompanied by a decrease in the resting cell membrane potential and an intracellular accumulation of sodium, calcium, and water, paralleled by loss of cellular potassium. These ionic imbalances are directly linked to the failure of energy-dependent pumps, like the sodium-potassium pump, necessary to maintain cellular integrity. Immunologic responses include alterations in macrophage function, which are key immune cells, and perturbations in both cellular and humoral immunity throughout the body.
The source describes the burn wound itself as a complex, dynamic injury with 3 distinct zones that evolve over time. Can you walk us through those?
Certainly. A thermal burn wound is characterized by a central zone of coagulation, where tissue is irreversibly damaged due to the heat causing complete capillary occlusion and protein denaturation. Surrounding this is an area known as the zone of stasis, where blood flow is compromised, it's sluggish, but tissue may still be potentially viable with appropriate intervention. This is the critical area for salvage. Bordering the area of stasis is the area of erythema, which is characterized by vasodilation and increased blood flow due to the inflammatory response. And this outer zone typically heals spontaneously without intervention.
How do these zones change over time, particularly in the crucial early hours?
The zone of coagulation isn't static. It can progress significantly during the early post-injury period due to ongoing ischemia and inflammatory processes. The source states it may progress by a factor of 10, meaning it can become 10 times larger or deeper during the first 48 hours after injury.
A factor of 10. Wow.
Crucially, this is a three-dimensional phenomenon, meaning the area of irreversible tissue damage can increase in both size and depth during this critical early window if interventions aren't successful in preventing it.
What happens specifically to the microcirculation, the tiny blood vessels in and around the burn?
Local microcirculation within and bordering the burn is compromised to the greatest extent during the 12 to 24 hours immediately following the burn. The wound remains in this dynamic state of flux, where progression or salvage can occur for up to 72 hours after injury. Ischemic necrosis, the death of tissue due to insufficient blood supply, quickly follows this compromise if blood flow isn't restored or maintained.
Are there changes in the blood itself within these vessels?
Yes, hematologic changes occur within the microcirculation, including the formation of platelet microthrombi, small clots, and hemoconcentration, an increase in the concentration of blood cells due to fluid loss, particularly in the postcapillary venules, the small veins receiving blood from capillaries.
And what drives the rapid edema formation, the massive swelling that is so characteristic of burns, both locally and systemically?
Edema formation is rapid and extensive in the injured area due to several factors. There's a massive increase in capillary permeability, allowing fluid and proteins to leak out. A decrease in oncotic pressure within the vessels because proteins are lost. An increased interstitial oncotic pressure as proteins accumulate in the tissue space. And changes in the interstitial space compliance, meaning it becomes easier for fluid to accumulate, along with lymphatic damage which impairs fluid drainage.
And it's not just local, right?
No, exactly. While edema is most prominent in the directly involved burn tissues, it also develops significantly in distant, uninjured tissue throughout the body, including muscle, intestine, and lung. This distant effect highlights the systemic nature of the inflammatory response to a burn and the widespread vascular changes.
The source also describes changes occurring in the distant microvasculature.
Yes, even far from the burn site, including red cell aggregation, white cell adhesion to venular walls, and platelet thromboemboli. Figure 1 in the source illustrates tissue damage and thermal injury. It specifically depicts the impediment of circulation below the injury and shows a clot bifurcation, where a blood clot splits a venule. It really gives you a visual representation of these microcirculatory issues that hinder blood flow.
What role do inflammatory mediators play in driving this progressive damage and edema?
Inflammatory mediators are elaborated locally by damaged tissues and cells, and systemically, in part from activated platelets, macrophages, and leukocytes. This contributes significantly to the local and systemic hyperpermeability of the microcirculation, which appears histologically as gaps in the venular and capillary endothelium, the lining of the blood vessels. This is a progressive process that can extend dramatically during the first early days after injury. Figures 2A, 2B, and 2C in the source visually depict this endothelial damage progression. Figure 2A shows normal endothelium tight cellular borders, integrity. Figure 2B shows damaged endothelium with an influx of platelets and white cells between the cells and a loss of cellular borders. And Figure 2C illustrates further damaged endothelium with more influx of white cells and platelets, notable microthrombi forming, and a significant loss of the integrity of the endothelial lining. It clearly shows how these vessels become leaky and obstructed.
So the damage keeps going.
Yes, the ongoing tissue damage and thermal injury is due to multiple factors, including the failure of surrounding tissue to supply borderline cells with the oxygen and nutrients necessary to sustain viability. The impediment of circulation below the injury also results in desiccation, or drying out, of the wound, as wound fluid cannot be supplied via the thrombosed or obstructed capillaries. While topical agents and dressings may reduce desiccation, the source states they cannot prevent the inexorable progression to deeper layers if the underlying microcirculation remains compromised.
So the altered vascular permeability that causes edema isn't just from the direct heat injury itself.
No, altered permeability is not solely caused by the thermal heat injury. Oxidants and other mediators, such as prostaglandins, kinins, cytokines, histamine, and interleukins, all contribute to increased vascular permeability. Neutrophils, a type of polymorphonuclear leukocyte, in particular, are highlighted as a major source of oxidants and injury within the ischemia reperfusion mechanism.
Ah, ischemia reperfusion again.
Yes, a complex process where tissue damage occurs not just during the initial lack of blood flow, ischemia, but also upon restoration of flow, reperfusion. This reperfusion injury mechanism is something that may be positively impacted by several interventions, including, according to the source, hyperbaric oxygen.
And how does all of this complex pathophysiology shape the primary focus of burn therapy in those critical early hours and days?
Well, given this detailed understanding, therapy is strategically focused on the reduction of dermal ischemia, preserving blood flow to the skin, the reduction of edema, and the prevention of infection. The source emphasizes that during the period of early hemodynamic instability and burn shock, edema reduction has a markedly beneficial effect. It plays a crucial role in modulating later wound conversion from potentially salvageable partial thickness injury to irreversible full thickness injury.
So reducing edema helps save tissue.
Exactly. Reducing edema helps preserve microcirculation and improve tissue oxygenation.
And healing.
Healing is also significantly retarded until equilibrium is achieved in the wound environment. Regeneration cannot take place effectively before that stabilization occurs. A prolongation of the healing process, particularly for deeper partial thickness wounds, may lead to excessive scarring. The source provides a memorable and clinically relevant statistic on this link. Hypertrophic scars, those raised, thickened scars. They're observed in only 4% of cases, taking 10 days or less to heal.
Only 4%.
Right. But this incidence rises significantly to 14% of cases, taking 14 days or less, jumped sharply to 28% of cases, taking 21 days to heal, and is seen in up to 40% of cases, taking longer than 21 days to heal.
40%.
Yes. This provides a concrete quantitative link between healing time and long-term cosmetic and functional outcome, highlighting the clinical importance of accelerating healing.
Okay, another micro recap needed here for pathophysiology.
That's good.
A major burn triggers severe systemic physiological changes, including burn shock, complex metabolic derangements like decreased cellular adenosine triphosphate, and widespread immune system perturbations.
Right. The wound itself has dynamic zones, coagulation, stasis, and erythema, with the zone of irreversible damage expanding significantly early on due to ongoing ischemia and inflammation.
Microcirculatory compromise, platelet microthromby, white cell adhesion, and rapid extensive edema formation, both locally and distantly, are driven by inflammatory mediators and oxidative stress, contributing to progressive damage and potential conversion to deeper injury.
And therapy focuses on mitigating ischemia, edema, and infection, with early edema reduction being particularly key.
Finally, prolonged healing time is strongly linked to increased hypertrophic scarring, underscoring the importance of therapies that might accelerate tissue repair.
Precisely.
Infection is clearly a major threat in burn patients, stated in the source as the leading overall cause of death. Why are burn patients so uniquely susceptible compared to other trauma patients?
Their susceptibility to infection is increased for several critical and interconnected reasons. First, and most obviously, there is the massive loss of the integumentary barrier, the skin, which is our primary physical defense against bacterial invasion.
The barrier's gone.
Gone. Second, the burn wound itself presents an ideal substrate for bacterial growth, providing damaged tissue and fluid that can support microbial proliferation. Third, the compromised or obstructed microvasculature within and around the burn prevents essential humoral elements like antibodies and cellular elements of the immune system, like white blood cells, from effectively reaching the injured tissue to fight invading pathogens.
So the defenses can't even get there.
Exactly. And additionally, the immune system of burn patients is seriously affected systemically far beyond the local wound. This manifests as decreased levels of immunoglobulins, key antibody molecules, and profound perturbations of polymorphonuclear leukocyte function. These polymorphonuclear leukocyte dysfunctions include disorders of chemotaxis, that's the ability of these cells to move toward the site of infection-impaired phagocytosis, their ability to engulf and destroy pathogens, and diminished killing ability. The source highlights that these specific functional deficits in polymorphonuclear leukocytes significantly increase both morbidity or illness and mortality or death in burn patients. The source also mentions an interesting finding that certain patients with specific genetic variations or polymorphisms in genes related to tumor necrosis factor and bacterial recognition may have a higher incidence of sepsis than the severity of their burn injury alone would predict.
So a genetic predisposition.
Potentially playing a role, yes. And more recently, fungal infections, in addition to bacterial ones, have become an increasing therapeutic challenge in this patient population.
Okay, quick recap on infection.
Right. The loss of skin barrier, the wound itself as a breeding ground, and critically, the compromised microcirculation within the wound combined with systemic immune deficits, including profound dysfunction of polymorphonuclear leukocytes in their ability to find, engulf, and kill pathogens, make burn patients highly susceptible to infection.
And this susceptibility is a major driver of mortality, compounded by potential genetic factors and the increasing challenge of fungal infections. Therapies that can improve host defense or blood flow to the wound might mitigate this risk.
Absolutely.
Now, let's turn to the extensive experimental data presented in the source. The authors state that the efficacy of adjunctive hyperbaric oxygen therapy in thermal injury is supported by both a significant body of animal studies and human clinical data. Let's start by detailing the findings from the animal studies they highlight.
There is indeed a significant body of animal data, accumulated over decades, that explores the effects of hyperbaric oxygen on burn wounds. One of the most consistently demonstrated findings across various animal models is edema reduction. Hyperbaric oxygen therapy has shown this effect in studies using burned rabbits, rats, mice, and guinea pigs. They reference specific foundational studies such as those by Gruber in 1970, Wells and Hilton, Nylander, and Kaiser.
What about the impact on healing time in these animal models?
Improvement in healing time has also been reported in burned rabbits by Ketchum, and in rats by Hartwig and Kirst, and by Miller and Korn. Faster healing is a critical goal, as we discussed earlier regarding scarring.
Definitely. And were there observations regarding infection rates in these animal studies?
Decreased infection rates were noted as an additional observation in some of these animal models treated with hyperbaric oxygen, specifically referenced in studies by Ketchum and Miller and Korn. This aligns with the clinical challenge of infection being a major cause of death.
You mentioned Gruber's 1970 study. What was key there?
Well, that was a seminal study establishing an early mechanistic insight. Gruber demonstrated experimentally that the area of viable skin tissue within a burn could be increased by hyperbaric oxygen administered at pressure. Figure 3 in the source visually supports this. It compares the capillary state in a control animal versus a hyperbaric oxygen-treated animal. The left panel shows organized capillary arcades and intact circulation in the treated animal, while the right panel depicts significant capillary disorganization, inflammation, and leakage of contrast agent in the control animal. It visually reinforces the idea that hyperbaric oxygen helps preserve the microcirculation and potentially salvage tissue in the zone of stasis.
How was the microvasculature improvement specifically demonstrated in other studies?
Ketchum, in studies from 1967 and 1970, reported improvement in healing time and reduced infection, and later demonstrated dramatic improvement in the microvasculature of burned rats treated with hyperbaric oxygen. He showed preserved capillary flow where flow was lost in controls. And Figure 4 shows tissue oxygen tension measurements. It graphs the mean oxygen tension of normal skin and various hypoxic tissues, including third-degree burns and composite skin grafts, as a function of increasing hyperbaric oxygen pressure.
Okay.
Notably, it shows that oxygen tension rises significantly in burned skin only with increasing ambient pressure with 100% oxygen. This illustrates how hyperbaric oxygen can overcome the low tissue oxygen levels in the burn wound, which is crucial for cellular survival and function. Hartwig and Kirst in 1974 confirmed these microvasculature findings and additionally noted less inflammatory response in treated animals, suggesting hyperbaric oxygen might be a useful adjunct to early debridement techniques by reducing inflammation.
The source mentions a carefully designed experiment by Wells and Hilton looking at fluid loss. What did they find?
Wells and Hilton, in a controlled experiment using 40% flame-burned dogs, reported a marked decrease of 35% in fluid extravasation, the leakage of fluid out of the blood vessels. The source points out that their study clearly showed this significant effect was related to the increased oxygen provided by hyperbaric therapy, not simply to the increased pressure itself.
An important distinction.
Very important. They also noted a reduction in hemoconcentration, meaning the blood didn't become as thick, and improved cardiac output, relating this directly to the prevention or mitigation of burn shock, which is characterized by significant fluid loss and decreased cardiac function. Figure 5 visually presents their findings on plasma volume losses. It compares untreated animals breathing normal air, animals exposed to pressure alone breathing normal air at 2 atmospheres absolute, and animals treated with hyperbaric oxygen at 2 atmospheres absolute breathing 100% oxygen. The hyperbaric oxygen group shows significantly less plasma volume loss, strongly supporting its role in preventing burn shock.
And what about generalized edema, the swelling that happens even in distant, unburned tissues?
Nylander, In a well-accepted animal model using the rabbit ear burn, showed that hyperbaric oxygen reduced the generalized edema associated with burn injury. Figure 6 illustrates this by showing the reduced water content, a quantitative indicator of edema in the contralateral unburned ear of burned animals treated with hyperbaric oxygen compared to burned animals that were controls and did not receive hyperbaric oxygen. This suggests a systemic effect on edema beyond just the directly burned site.
The source mentions Kaiser's work on third-degree injury. What did that study report?
Kaiser reported that hyperbaric oxygen treatment resulted in shrinkage of third-degree or full-thickness injury in a rabbit model. Untreated animals demonstrated the expected increase in wound size during the first 48 hours, a common phenomenon of burn wound progression, while treated animal wounds remained smaller at all time points. A reduction in subcutaneous edema, the swelling under the skin, was also observed in this study. Figure 7 is referenced here, titled Tissue Oxygen Tension. However, the text description accompanying it details a reduction in subcutaneous edema in full thickness, burned animals treated with hyperbaric oxygen, and progression of the burn wound in controls while treated wound size decreased. This seems to align with the edema finding reported by Kaiser, suggesting a possible mismatch in the figure title as presented at the source itself.
Okay.
Regardless of the figure label, the key takeaway from Kaiser's work as presented is the reported reduction in full-thickness injury size and associated edema with hyperbaric oxygen.
Stewart and colleagues did a study looking at deep partial thickness burns.
Yes, a particularly insightful study. They subjected rats to controlled burn wounds designed to result in deep partial thickness injury, the kind most likely benefit from tissue salvage efforts. Both groups, experimental receiving hyperbaric oxygen and control, were treated with standard topical agents, specifically silver sulfadiazine dressings, according to a later reference. The hyperbaric oxygen-treated animals showed striking preservation of dermal elements. Importantly, no conversion from partial to full thickness injury and preservation of cellular adenosine triphosphate level.
And no conversion?
No conversion. The untreated animals demonstrated a marked diminution in cellular adenosine triphosphate levels and conversion of their potentially salvageable partial thickness injury to full thickness, requiring grafting.
That's a fascinating link between a cellular energy molecule, ATP, and clinical outcome. What's the significance of the adenosine triphosphate finding?
Well, since the production of adenosine triphosphate takes place primarily in mitochondria, this study demonstrated prevention of mitochondrial death and preservation of mitochondrial function in the treated animals. This finding is directly related to the preservation of energy sources necessary for critical cellular processes like the sodium pump in cellular physiology. Failure of the sodium pump due to lack of adenosine triphosphate is believed to be a major factor in the ballooning of endothelial cells that occurs after burn injury and contributes to the subsequent massive fluid losses and edema. This links this cellular mechanism to the clinically observed edema reduction and microcirculatory preservation.
Oh.
Figure 8, titled Rat Burns Treated, shows the adenosine triphosphate levels over time of the hyperbaric oxygen-treated groups once daily and twice daily treatments compared to the control group, clearly illustrating the preservation of adenosine triphosphate with hyperbaric oxygen treatments. And Figure 9, partial thickness burns, shows biopsy images at 5 days. The left panel, A, shows preserved dermal elements like hair follicles and glands in hyperbaric oxygen-treated animals. The right panel, B, shows significant coagulation necrosis or tissue death in non-treated animals. It visually demonstrates the prevention of conversion and preservation of tissue structure.
Very clear. What other key findings came out of the animal studies?
Other important findings include German prey reporting decreased extension of burn injury with hyperbaric oxygen. Miller and Korn demonstrated earlier return of capillary patency blood flow restored sooner, with a statistically significant p-value of less than 0.05 in guinea pigs using an India ink injection technique to visualize vessels. They also reported faster reepithelialization, the regrowth of the skin surface, with a statistically significant p-value of less than 0.001 from regenerative sites in treated guinea pigs compared to controls. The observed decrease in wound desiccation, or drying out, in the treated group was attributed to the preservation of capillary integrity and fluid supply in the zone of stasis. Saunders and colleagues similarly reported improved dermal circulation, preservation of dermal elements, and less collagen denaturation with hyperbaric oxygen treatments, all indicating tissue preservation. Blizer and Beneschot, in a large controlled study in a rat model of 30% total body surface area burns, reported reduced burn shock and a remarkable 4-fold increased survival in hyperbaric oxygen-treated animals versus controls.
A 4-fold increase in survival, that's huge.
A direct impact on mortality in that model, yes.
The source also discusses the impact on immune function in animal models, specifically polymorphonuclear leukocyte.
Yes. Reduction of polymorphonuclear leukocyte killing ability in hypoxic tissue has been well documented. These vital infection-fighting cells don't function optimally in low oxygen. The ability of hyperbaric oxygen to elevate tissue oxygen tension in the wound and the enhancement of polymorphonuclear leukocyte killing in an oxygen-enriched environment, as demonstrated by Mader and colleagues, shows this is an additional benefit of hyperbaric oxygen in the context of a burn wound, which can be significantly hypoxic. This could potentially improve the host's defense against infection.
And importantly,
Hussman and colleagues have shown no evidence of hyperbaric oxygen-induced immunosuppression in a carefully controlled animal model, addressing a potential concern that high oxygen could harm the immune system.
what about more recent animal studies, Billick et al. In 2005?
Yes, that was a randomized controlled study evaluating the effects of hyperbaric oxygen on burn wound healing. They produced standard deep second-degree burns in male Wistar rats treated with silver sulfadiazine dressing. Then they randomly assigned the animals to either a normoxic placebo gas, normal air at normal pressure, or to 2.5 atmospheres, absolute hyperbaric oxygen for 60 minutes for a total of 21 sessions. The study found that hyperbaric oxygen had significant beneficial effects on post-burn edema, P0.022, neoangiogenesis or new blood vessel formation, P0.009, the numbers of regenerative active follicles like hair follicles, P0.009, and the time to epithelial regeneration, P0.048.
All statistically significant.
Yes, all key indicators of improved healing and tissue preservation. There were no significant differences noted in necrosis staging or the margination of leukocytes in this particular study. The authors concluded that their data supported earlier conclusions that hyperbaric oxygen is beneficial in healing burn wounds.
And Turkislan et al.
Another recent report by Turkislan and colleagues found that hyperbaric oxygen treatment reduced the progression of the zone of stasis in the first 24 hours after injury and accelerated the healing process by supporting neoangiogenesis. As preventing progression in the zone of stasis is a major goal in burn therapy, aiming to salvage potentially viable tissue, this report lends further credence to the previously cited work of Miller, Korn, Hartwig, Ketchum, and Stewart.
Okay. The source also addresses studies that are often cited as having negative findings regarding hyperbaric oxygen in burns. What are those studies, and how does the source interpret them in light of the broader evidence?
Right. Two studies are frequently cited negatively. One is by Perens, published in 1970. This study, using a porcine scald model, failed to demonstrate modification of progressive tissue destruction. However, the source explains that this study likely failed to show a positive outcome due to significant limitations in its protocol. Oxygen was administered at only 2 atmospheres absolute for just 1 hour, and treatment occurred over a 1-day period only.
Very limited exposure.
Extremely limited. With such a short duration and limited frequency, particularly in the critical early window, the source argues, one wouldn't expect to see any positive outcome given the dynamic nature of burn progression. Additionally, no vascular studies were undertaken in this experiment to assess microcirculatory changes. It's also noted that the porcine model itself may not be appropriate for drawing conclusions applicable to human burns, given specific features about pigs. Their natural resistance to skin infection, skin that doesn't form a blister following a scald wound injury like human skin does, and a lack of many shared dermal elements with humans, including cutaneous sweat glands. These physiological differences might make the pig model less sensitive to the effects of hyperbaric oxygen seen in other species or humans.
Okay, and the other negative study, Nicole.
Yes. The Nicole study reported that hyperbaric oxygen provided no advantage in treating full thickness and partial thickness burns, either alone or in combination with topical antibiotic therapy, in controlling bacterial counts in a rat model. However, the source highlights a critical point within this study that is often overlooked. Despite the negative finding on bacterial counts, and despite a treatment delay of 12 hours before initiating therapy after injury.
That's just quite late.
Quite late. The same study found that hyperbaric oxygen significantly reduced the time to complete epithelialization in a partial thickness burn injury. This is a contradictory finding, within the same paper reporting no overall advantage, while also reporting a significant positive effect on healing time.
Interesting. And Shoshani et al.
A third study mentioned as reporting no benefit, meaning no difference in wound size, reepithelialization rate, Doppler blood flow, or healing, is by Shoshani and colleagues. They reported no benefit of hyperbaric oxygen in a rat burn model where all animals received standard sulfadiazine topical treatment. In this report, the author made what the source calls an erroneous statement, claiming this is a first study utilizing standard burn care, meaning topical agents. The source contrasts this with the earlier study by Stewart's group, which did utilize silver sulfadazine dressings and confirmed the preservation of dermal elements with hyperbaric oxygen. The source suggests that the contradictory findings between Shoshani's study, no benefit, and Stewart's study, preservation of tissue and energy levels with hyperbaric oxygen and standard topical care, might be explained by methodological differences between them, perhaps related to the specific burn model severity or timing duration of hyperbaric oxygen.
Okay, let's do an end-of-chapter mega recap on the experimental data.
Right. So the source presents an overwhelming body of evidence from a large number of control animal studies conducted over 5 decades. This evidence consistently demonstrates multiple benefits of hyperbaric oxygen in thermal injury, including the reduction or prevention of burn shock, dermal ischemia, and edema. It prevents the progression of partial to full thickness injury, maintains the microcirculation, and preserves mitochondria, adenosine triphosphate production, and cellular integrity.
And also,
Additional reported benefits include the enhancement of polymorphonuclear leukocyte killing and the modulation of ischemia reperfusion injury, ultimately resulting in improved survival in animal models. These mechanisms act in concert to mitigate the key pathophysiological processes that drive morbidity and mortality in thermal burns.
and the negative studies.
The studies often cited negatively are addressed by the source, which suggests reasons for their lack of reported positive findings, methodological limitations, inappropriate animal models, or failure to examine relevant outcomes, while also noting that some of these studies contain contradictory positive findings that are often overlooked when they are broadly labeled as negative.
Moving on, the source draws a striking similarity between the pathophysiological changes that occur within the burn wound and those noted in ischemia reperfusion injury. Can you elaborate on that comparison and why it's relevant to hyperbaric oxygen?
Yes, the source points out that the pathophysiologic changes within the burn wound, particularly in the zone of stasis and the surrounding tissue, show a striking similarity to those noted in ischemia reperfusion injury that occurs in other tissues after temporary loss of blood flow. They list several common features shared by both processes at the cellular and molecular level. Depletion of cellular adenosine triphosphate, production of xanthine oxidase, an enzyme that generates harmful reactive oxygen species, lipid peroxidation, damage to cell membranes, activation of polymorphonuclear cell, neutrophils, with subsequent adherence to the endothelium, and the generation of reactive oxygen species themselves, which cause oxidative damage.
Has hyperbaric oxygen shown benefits in other ischemia reperfusion models in the body?
Indeed. The source mentions that the beneficial effects of hyperbaric oxygen in ischemic reperfused tissues have been demonstrated in various areas of the body outside of burns. These include the intestine, skeletal muscle, brain, testicular tissue, and myocardium, the heart muscle. This existing evidence from other tissues subjected to ischemia reperfusion lends significant weight to its potential role in mitigating the similar process occurring within burn wounds.
Is there specific evidence in burn patients linking hyperbaric oxygen to these inflammatory markers?
Yes, a specific study mentioned is by New and colleagues, who looked at severely burned patients with greater than 30% total body surface area burns. They found that hyperbaric oxygen-treated patients, compared to controls who received standard care, had increased levels of serum-soluble interleukin-2 receptor, an inflammatory marker, P0.05, and decreased plasma fibronectin, a protein involved in tissue repair and inflammation, P0.01. Clinically, these favorable changes in inflammatory markers were associated with a lower incidence of sepsis, that life-threatening infection response, with a statistically significant p-value of less than 0.05 in the hyperbaric oxygen-treated group.
The source also discusses recent data regarding hyperbaric oxygen and its effects on cardiac tissue and preconditioning.
Yes, recent data regarding hyperbaric oxygen, cardiac preconditioning inducing cellular tolerance to ischemia, and adaptive responses resulting in cardioprotection and attenuation of ischemia reperfusion injury in the heart muscle are discussed. These protective effects are reported to be mediated by hyperbaric oxygen-induced reactive oxygen species, specifically superoxide and hydrogen peroxide, generated during the high oxygen exposure.
Wait, reactive oxygen species are usually bad, right?
Well, yes, they're usually associated with damage. But at specific levels induced by hyperbaric oxygen, they appear to act as signaling molecules that stimulate the production of protective factors, including nitric oxide.
How do these hyperbaric oxygen-induced reactive oxygen species contribute to the protective effect at a molecular level?
Hyperbaric oxygen-induced reactive oxygen species are known to initiate beneficial gene expression changes, and reduced neutrophil adhesion to the endothelium. This happens through a decrease in the function of molecules like CD11A18 and p-selectin, and importantly, through the downregulation of intracellular adhesion molecule 1, or ICAM1. That's a key molecule white blood cells use to stick to the blood vessel lining.
Okay.
Additionally, hyperbaric oxygen is reported to decrease overall lipid peroxidation, stimulate neovascularization, new blood vessel formation, and increase the production of beneficial antioxidants, thus resulting in cellular and tissue cardioprotection. The source suggests that elucidating these specific molecular mechanisms may provide further understanding of how hyperbaric oxygen is beneficial in acute thermal injury, given the similarities to ischemia reperfusion.
Is there a key finding about blocking that reperfusion cascade?
Yes. A key finding specifically relevant to blocking the harmful cascade comes from Zamboni's model of reperfusion injury. It demonstrated experimentally that hyperbaric oxygen is a potent blocker of white cell adherence to endothelial cell walls in skeletal muscle. This adherence is a critical early step in the inflammatory cascade that causes vascular damage during reperfusion. Hyperbaric oxygen effectively interrupts this cascade. The proposed mechanism for this is an inhibitory effect on the CD18 locus, which is part of the integrin molecule complex CD11A18 that mediates white cell binding.
How does that finding about blocking white cell adherence relate back to the burn wound pathophysiology we discussed, particularly the progressive microcirculatory compromise?
As discussed by Wasiak and colleagues and highlighted in the source, the inhibition of beta-2 integrin activation of intracellular adhesion molecule 1, or ICAM1, by hyperbaric oxygen enables tissues to maintain microvascular flow in areas that would otherwise be subject to the well-described secondary injury following a thermal burn. The secondary injury is driven by inflammation and microvascular obstruction.
And this effect lasts.
Yes. This beneficial effect on white cell adhesion and preservation of microvascular flow has been shown to persist for some hours after hyperbaric oxygen exposure, as demonstrated by both Ueno and colleagues and Milchigov-Jlolik and colleagues. German praise data is also mentioned as supporting this observation of improved microcirculation and potentially explaining the beneficial effect of hyperbaric oxygen on the microcirculation that had been previously observed in earlier animal and human studies. The source suggests that more studies in this specific area of ischemia reperfusion mechanisms and white cell endothelial interaction will be fruitful.
Okay, quick recap on reperfusion injury mechanisms.
Right. The source highlights the striking similarities between burn wound pathophysiology and ischemia reperfusion injury, characterized by energy depletion, oxidative stress, and white cell activation adhesion.
Hyperbaric oxygen has shown benefit in treating ischemia reperfusion in various organs outside of burns.
Yes, and specific studies in burn patients demonstrate its impact on inflammatory markers, like soluble interleukin-2 receptor and fibronectin, associated clinically with reduced sepsis. Proposed molecular mechanisms involve hyperbaric oxygen-induced reactive oxygen species acting as signaling molecules that stimulate nitric oxide production, initiate beneficial gene expression, reduce neutrophil adhesion via effects on molecules like CD11A18, p-selectin, and ICAM1, block white cell adherence to endothelium via the CD18 locus, decrease lipid peroxidation, stimulate new vessel formation, and enhance antioxidant production.
And this complex interplay is suggested to protect tissue and maintain microvascular flow, preventing the progressive secondary injury that expands the burn wound.
Exactly.
The source returns to the critical problems of immunity and infection, this time focusing on bacterial translocation and gut ischemia reperfusion injury as contributors to systemic complications.
Yes. They specifically revisit the issue of infection and immunity, drawing a crucial link to bacterial translocation from the gut. Tenenhaus and colleagues are cited for showing a reduction in mesenteric bacterial colonization. Fewer bacteria found in the lymph nodes, draining the intestine, with a statistically significant p-value of less than 0.005 in a hyperbaric oxygen-treated burned mouse model compared to controls. Bacterial translocation, the movement of bacteria or their products from the gut into the bloodstream and tissues, is widely believed to be a major source of burn wound infection and systemic complications.
How is bacterial translocation from the gut linked to systemic problems like multiple organ dysfunction syndrome and severe burns?
In 2005, Magnani and colleagues proposed an evolution from bacterial translocation to gut ischemia reperfusion injury after a burn as a key pathogenesis or development process of multiple organ dysfunction syndrome. Systemic inflammation, acute lung injury, and multiple organ failure are common causes of significant illness and death after a major thermal injury.
So the gut barrier breaks down.
In a normal, healthy individual, the intestinal mucosa, the lining of the gut, functions as a major local defense barrier, preventing gut bacteria and their products like endotoxin from crossing into the bloodstream. However, after major thermal injury and in other critical illness states, this intestinal barrier function becomes overwhelmed or impaired due to decreased blood flow and inflammation. This results in the movement of bacteria and endotoxin to the mesenteric lymph nodes, which are part of the immune system draining the gut, and then systemically to other tissues. That's bacterial translocation.
Given the bacterial load in the gut, this barrier function seems incredibly important.
Oh, absolutely critical. The source emphasizes the importance of this intestinal barrier by highlighting the sheer concentrations of microorganisms in endotoxin present in the distal small bowel and colon. These areas can contain 10 to the power of 11 concentrations of anaerobes, bacteria that don't need oxygen, and 10 to the power of 5 to 10 to the power of 8 each of gram-positive and gram-negative aerobic and facultative microorganisms per gram of tissue.
That's astronomical.
It amounts to enough endotoxin, a potent inflammatory molecule from gram-negative bacteria, to kill the host thousands of times over if it breaches the barrier and enters the systemic circulation.
So the consequences of barrier failure are severe.
Yes, the loss of gut barrier function and the resultant gut inflammatory response lead to the production and release of pro-inflammatory factors. This can trigger a systemic septic state, ultimately leading to distant organ failure throughout the body. Splanchnic hypoperfusion, meaning reduced blood flow to the abdominal organs, leading to gut ischemia reperfusion injury, appears to be the dominant hemodynamic event that triggers the release of biologically active factors into the mesenteric lymphatics, propagating the systemic inflammatory response cascade.
So how might adjunctive hyperbaric oxygen therapy fit into this complex picture of gut-derived complications?
The source suggests, based on findings like the reduced bacterial translocation in the mouse model, that the benefits of the early use of hyperbaric oxygen in burn victims may be partly mediated through amelioration or improvement of this gut reperfusion injury process. It potentially preserves gut barrier function and reduces the release of harmful factors.
What about nutrition?
They also mention, in this context, the recommendation for total enteral nutrition, starting as early as possible after thermal injury, for burn patients. This nutritional support is known to result in decreased morbidity and mortality and supports intestinal structure and function, complementing efforts to maintain gut health. Studies of intestinal barrier function show that the ischemic and/or stressed gut can become a pro-inflammatory organ. Gut-derived factors liberated after periods of splanchnic hypoperfusion can lead to acute distant organ failure, cellular dysfunction, and activation of neutrophils and other pro-inflammatory cells, contributing to the systemic inflammatory response syndrome seen in severe burns.
Okay, let's recap this section on immunity, infection, and the gut.
Right. Infection remains a major threat, driven in part by compromised defenses and the burn wound.
Bacterial translocation from the gut, potentially triggered by gut ischemia reperfusion injury due to splanchnic hypoperfusion, is proposed as a key pathogenesis for multiple organ dysfunction syndrome after major burns.
And the gut barrier is critical given the massive microbial load within the intestines.
The source suggests that hyperbaric oxygen may help ameliorate this gut reperfusion injury and reduce bacterial translocation, contributing to its overall benefits in mitigating systemic inflammation and complications.
Correct.
The source also highlights interesting and more recent findings regarding hyperbaric oxygen and its effects on stem cells.
Yes, there are compelling findings in this area that propose another mechanism for hyperbaric oxygen's benefits, particularly in tissue repair and regeneration. Hyperbaric oxygen has been shown experimentally to mobilize stem and progenitor cells from the bone marrow into the circulating bloodstream in both humans and mice. This mobilization is reported to occur by stimulating bone marrow stromal cell type 3. Those are endothelial cells, nitric oxide synthase, an enzyme that produces nitric oxide.
What happens to these mobilized stem and progenitor cells once they are circulating?
Findings indicate that some of the mobilized cells will home, meaning they migrate to peripheral sites, including wound areas. Once at the wound site, they function as de novo endothelial progenitor cells, meaning they are newly formed progenitor cells destined to become endothelial cells, the cells that line blood vessels. These endothelial progenitor cells are described as contributing to wound vasculogenesis, the formation of new blood vessels from these circulating progenitor cells, acting as a complement to local angiogenesis, which is new vessel formation from pre-existing ones.
So both processes are helped.
Yes, both are essential for wound healing, and this suggests hyperbaric oxygen influences both. Additionally, the source notes that at these peripheral sites, like the burn wound, Hyperbaric oxygen stimulates stem cell growth and differentiation by engaging a physiological autocrine loop responsive to oxidative stress, much the same way that lactate does. They explain a specific pathway involved. Hyperbaric oxygen stimulates peripheral site, endothelial progenitor cells recruitment and differentiation via a pathway involving thyrodoxin-1, hypoxia-inducible factors 1, HIF-1, and hypoxia-inducible factors 2.
HIF factors.
Yes, transcription factors involved in cellular response to oxygen levels. These findings, the source states, provide new insight into possible complex cellular mechanisms for the known clinical benefits of hyperbaric oxygen in promoting tissue repair and regeneration.
Are there specific numbers reported regarding the extent of stem cell mobilization seen with hyperbaric oxygen?
Yes. Tom and colleagues are specifically reported as finding in experimental models that hyperbaric oxygen increases marrow stem cell populations by a remarkable 800%.
800%.
800%. And that these cells migrate from the bone marrow to areas of wounding. This is an extraordinary increase in the circulating pool of reparative cells.
How does this finding about stem cell mobilization connect back to earlier points about preserving dermal elements like hair follicles in animal studies?
The source connects the previously reported preservation of dermal elements, specifically mentioning hair follicles, as observed by Stewart and colleagues in their rat burn study, to this stem cell finding. They suggest that this preservation of structures containing stem cell populations, like hair follicles, may represent an additional area for the recruitment and activation of native stem cells within the wound itself to aid in healing.
So, circulating and local stem cells?
Exactly, complementing the recruitment of circulating stem cells. There is currently significant interest in the burn community in using stem cell therapy for patients where prolonged healing is a major problem. And the source suggests that further research in this specific area related to hyperbaric oxygen's ability to mobilize and activate stem cells promises to be very productive.
Okay, let's recap the stem cell findings quickly.
Hyperbaric oxygen mobilizes bone marrow stem and progenitor cells into circulation in humans and mice, significantly increasing marrow populations by a reported 800%.
These circulating cells, home to wound sites, acting as endothelial progenitor cells and contributing to vasculogenesis, the formation of new blood vessels.
Right. Hyperbaric oxygen also stimulates the growth and differentiation of stem cells locally at peripheral sites via specific pathways involving molecules like thyrodoxin-1, HIF-1, and HI-2. This provides a new mechanistic explanation for observed clinical benefits in tissue repair and potentially explains the preservation of dermal elements like hair follicles, suggesting a role in recruiting both circulating and native stem cells, aligning with current interest in stem cell therapy for problematic burn healing.
Okay, let's try to synthesize this. A mega recap of the proposed mechanisms and the experimental data supporting them, according to the source.
Okay. The source presents an overwhelming body of evidence derived from a large number of controlled animal studies conducted over 5 decades, supported by findings in other ischemia reperfusion models and recent cellular research. This evidence demonstrates that hyperbaric oxygen reduces or prevents burn shock, dermal ischemia, and edema by preserving microcirculation and reducing vascular permeability.
It prevents progression.
Yes, it prevents the progression of partial to full thickness injury, maintains the microcirculation by blocking white cell adhesion to endothelium via the CD18 locus and reducing intracellular adhesion molecule 1, and preserves mitochondria, adenosine triphosphate production, and cellular integrity.
And other benefits.
Additional demonstrated benefits and mechanisms include the enhancement of polymorphin-nuclear leukocyte killing in hypoxic tissue, the modulation of ischemia reperfusion injury through antioxidant effects and reduction of inflammatory cascades, reduction of bacterial translocation from the gut, and the remarkable mobilization and activation of stem and progenitor cells that contribute to vasculogenesis and tissue regeneration. Ultimately, these multifaceted mechanisms working in concert are proposed to mitigate the key pathophysiological processes that drive morbidity and mortality in thermal burns and promote faster, more complete healing, resulting in improved survival in these experimental models.
Now let's transition from the experimental findings in animals and the proposed mechanisms to the human clinical experience reported in the source. How did initial observations in patients first suggest a role for hyperbaric oxygen in burn care?
Well, the initial observation, described as serendipitous or by chance, was by Wada in 1965. He noted improved healing of burns in coal miners who were being treated with hyperbaric oxygen for concurrent carbon monoxide poisoning sustained from mine fires.
Ah, interesting. Just happened to notice.
Exactly. This unexpected finding in a group of patients receiving hyperbaric oxygen for another reason sparked interest in its potential for burn treatment.
And what did later clinical series and studies in human burn patients show?
Later clinical series reported by Wada himself, and subsequently by Akita, Lamy, Tabor, and Grossman, consistently showed several reported benefits. These included improved healing rates, decreased length of hospital stay, decreased mortality, decreased overall cost of care, improved morbidity, meaning fewer complications, decreased fluid requirements during resuscitation, specifically noted as a 30 to 35% reduction in some reports. 30% reduction in fluid. Yes, and a decreased number of surgeries with a p-value reported as greater than 0.041, indicating a statistically significant reduction in the number of procedures required compared to control groups or historical data.
What about controlled trials? Hart et al. In 74.
Yes, a significant early human study reported by Hart and colleagues in 1974. This was a sham-controlled randomized series. One group received hyperbaric oxygen. The control group received a sham treatment mimicking some aspects of being in the chamber, but without the therapeutic oxygen dose. The study involved 147 patients with 10 to 50% total body surface area burns. Their study showed reduced fluid requirements, a significantly shorter mean healing time, p.005, as well as reduced mortality and morbidity in the hyperbaric oxygen-treated patients when compared both to the sham-controlled group and to historical data from the United States National Burn Information Exchange Standards.
And Nusu's large series from China.
Yes. New reported on a very large clinical outcome series comparing 266 seriously burned patients who received hyperbaric oxygen to 609 control patients who received standard care. This large series showed a statistically significant reduction in mortality, with a p-value of 0.028 in the seriously burned patients who received adjunctive hyperbaric oxygen compared to the control group. The author also observed a lower incidence of infection in the hyperbaric oxygen group and stated clinically that hyperbaric oxygen allowed the burn surgeon more time to accurately define the extent of the injury before committing to surgery. He also suggested a possible reduction in the need for surgery altogether, observations which agreed with earlier reports from other centers.
Grossman and colleagues also reported large series.
Yes, Grossman and colleagues in 1977 reported on a series of 236 patients treated with hyperbaric oxygen. Now, while the hyperbaric group in this series was significantly more seriously burned on average than the control group, their study showed a trend toward greater survival and strongly suggested a reduction in the risk of death, particularly in the more severely injured. They noted that full-thickness burns in the treated group were usually ready for grafting earlier in 10 to 26 days, compared to 14 to 21 days for those not treated with hyperbaric oxygen. This potentially reduces hospital stay and time to definitive wound closure.
And graft.
It was also the author's clinical impression that the percentage of graft take was greater in patients treated with hyperbaric oxygen and that donor sites reepithelialized at a faster rate, allowing for potential reharvesting sooner if needed. Grossman and colleagues provided further useful data in later reports from 1978 and 1982, detailing consistent decreases in fluid requirement, 25–30%, reduced second-degree burn healing time, faster Escher separation time, shorter donor reharvest time, fewer burn complications, decreased hospital stay, and reduced mortality. The source acknowledges that Grossman and colleagues continue to provide useful data, and their review remains relevant today.
Now, Weisbrand's study had a different take, right? Particularly on infection and mortality.
Yes, Weisbrand reported increased sepsis, reduced renal function, and decreased circulating white blood cells in hyperbaric oxygen-treated patients compared to controls. The author stated he could demonstrate neither a beneficial nor a harmful effect on mortality. However, despite these reported negative findings regarding infection markers and the conclusion regarding mortality, the source highlights a crucial detail often overlooked. There was a statistically significant 75% reduction in the need for grafting, p0.001, in the hyperbaric group within this study.
So a huge reduction in surgery needed, even if mortality wasn't affected in that study.
Exactly. It suggests the therapy did impact the need for surgical intervention significantly, even if the author didn't find a mortality benefit.
What about Marola and Piscitelli's study?
In a randomized controlled study involving 37 partial thickness burn patients treated with hyperbaric oxygen versus 37 controls, Marola and Piscitelli reported increased granulation tissue formation, faster healing times, and decreased scarring in the hyperbaric oxygen group.
And the authors of the source chapter, Cianci and colleagues, They conducted their own investigations.
Yes, and they reported several significant clinical findings from their experience. In studies of burns covering 40 to 80% total body surface area, they found a 54% reduction in surgeries for debridement or grafting in the hyperbaric oxygen group compared to controls,
Yeah.
1.04. In a second series where the control group averaged 48% TBSA burns and the hyperbaric oxygen group averaged 62% TBSA, a higher injury severity in the treated group, there was still a remarkable 64% reduction of debridement surgeries and endografting in the hyperbaric oxygen group.
64% reduction.
Yes, the hyperbaric oxygen group averaged 2.1 surgical procedures versus 7.8 in controls, p.03. In an additional study focusing on burns ranging from 18 to 39% TBSA, average 25%, the length of stay was 20.8 days in the hyperbaric oxygen group versus 33 days in controls, p. 0.012, a substantial reduction in hospital duration. The hyperbaric oxygen group in this study also showed an average savings of 36% in the cost of care per case.
They also did a blinded review looking specifically at fluid resuscitation.
Yes, in a later blinded review, Cianci and colleagues specifically looked at the fluid resuscitation phase in seriously burned patients, 40 to 80% TBSA, treated with adjunctive hyperbaric oxygen versus controls. They found a significant 25% reduction in resuscitative fluid requirements, p for 0.05, indicating less fluid was needed to stabilize these patients. A significant reduction in fluid output during the diuresis phase when excess fluid is mobilized was also noted, p.05. Furthermore, a significant 45% reduction in maximum weight gain on day 3, reflecting edema accumulation, was observed, p.03.
45% less weight gain.
Yes. The authors note, based on these findings, that there was a marked reduction of edema and smoother resuscitation in the hyperbaric oxygen-treated group, which could reduce complications associated with massive fluid shifts. Figure 10 visually presents the daily fluid intake, adjusted, showing lower intake in the hyperbaric oxygen group. Figure 11 shows the daily fluid output, also adjusted, indicating higher output in the hyperbaric oxygen group. And Figure 12 displays the maximum weight gain at 3 days, expressed as a percentage of admission weight, clearly illustrating that 45% reduction in weight gain in the hyperbaric oxygen-treated patients, p. 0.03.
What about Maxwell's pilot series?
Maxwell reported several positive outcomes in the hyperbaric oxygen group compared to controls, including reduced surgery, reduced resuscitative weight gain, fewer intensive care days, decreased total hospitalization time, reduced wound sepsis, and a lower cost of hospitalization.
And studies in human volunteers with controlled injuries. Hammerland.
Yes. Hammerland and colleagues showed reduced edema and wound exudation in a controlled series of human volunteers with UV-irradiated blister wounds. Figure 13, maximum length as function of time, shows the slower resolution of lesion size over time in the control group compared to the hyperbaric oxygen-treated group, suggesting faster resolution of the inflammatory response.
And Niezgoda et al. That was a double-blinded study.
Yes. Niezgoda and colleagues conducted a prospective, randomized, double-blinded control human study using sham controls with UV-irradiated suction blister wounds, designed to mimic a superficial burn with clear boundaries. Daily measurements were taken objectively. On day 2 after injury, significant differences were observed in the hyperbaric oxygen group compared to controls. A 42% reduction in wound hyperemia, redness, p.05, 35% reduction in the size of the lesion, p3.03, and a 22% reduction in wound exudation, whooping p.04.
All significant early effects.
Exactly. Importantly, no significant difference was realized for epithelialization, the closure of the skin surface, in this specific study. This suggests the early effects might be primarily on inflammation and edema rather than the final closure rate in this superficial model. Front 14A shows wound hyperemia measurements, 14B shows wound size, and 14C shows wound exudation measurements over several days, graphically illustrating these quantitative differences in the early inflammatory response.
What about long-term follow-up in that study? Scarring.
Assessment of the wounds in the Niezgoda study was also made at 6 months and 1 year post-study. There was no evidence of scarring noted at either time point. Minimal colorization or pigmentation changes was observed at 6 months, but this was completely resolved by 1 year.
And the source highlights this Niezgoda study.
Yes, the source highlights that this Niezgoda protocol is presented as the first prospective, randomized, double-blind trial of hyperbaric oxygen in human subjects, specifically designed to measure the early effects on inflammation and edema in a controlled wound model to report statistical significance for these objective endpoints. It states that this data provides strong support for additional clinical trials and utilization of hyperbaric oxygen for wound healing and burns, particularly regarding its early anti-inflammatory and anti-edema effects.
Let's discuss the Brannon and colleagues study from 1997 in more detail. The source presents this study as one that is often cited negatively, leading to controversy, but which, according to the source, actually included important positive observations and had significant limitations.
Yes, this study is frequently presented as concluding a limited or no significant positive impact of hyperbaric oxygen for burn patients. Brannon et al. Reported on a randomized prospective trial. 63 patients receiving hyperbaric oxygen, 52 controls receiving standard burn care. The authors reported finding no statistically significant difference in the primary outcome measures of mortality, number of operations, or length of hospital stay between the two groups. This led them to state in their conclusion that they were unable to demonstrate any significant benefit to burn patients from the routine use of hyperbaric oxygen.
But the source provides a critical analysis and points out serious limitations.
Absolutely. And these limitations, according to the source, are critical to understanding the study's findings. First, treatment timing. 2/3 of the hyperbaric oxygen-treated patients didn't receive their first treatment until more than 8 hours after burn injury, with a mean time to first treatment of 11.5 hours.
That's very late for impacting early dynamics.
Yes, exactly. Given the rapid nature of burn wound progression and edema formation in the first 24-72 hours, delaying the initial treatment significantly may have diminished the potential benefits. The source notes that results in the subset of patients receiving earlier treatment were not examined separately in their analysis, potentially masking an early benefit.
What else?
Second, important outcome measures that hyperbaric oxygen is clinically thought to impact were not studied. The study focused on broad measures like mortality and total length of stay, but specifically excluded examining the functional and cosmetic aspects of facial, hand, and perineal burns areas where tissue preservation is paramount. Third, confounding influences. Outcome measures like length of stay, number of surgeries, and extent of grafting are subject to a variety of external factors: economic pressures, hospital policies, insurance rules, social support availability. These can significantly impact outcomes independently of the therapy. Fourth, heterogeneity. Despite randomization for age, burn size, and inhalation injury, the study populations were still heterogeneous in other aspects, and comorbidity, which significantly impacts outcomes, wasn't examined.
And finally,
and significantly, all patients in this study, both groups, underwent exceedingly early and aggressive excisional therapy with rapid discharge. This aggressive standard burn care itself aims to reduce length of stay and procedures and might have potentially masked or minimized any additional benefits provided by adjunctive hyperbaric oxygen. These benefits might be more apparent with less aggressive early surgical strategies or in centers with different discharge philosophies.
but Brannon et al. Did make some positive observations.
Yes, despite their formal conclusion, the source highlights that Brannon and colleagues did observe less fluid loss during resuscitation and drier wounds in the hyperbaric oxygen group, which necessitated fewer dressing changes and appeared to heal earlier. These positive qualitative observations were acknowledged by the authors within their paper. The source also includes an anecdote about Dr. Joseph Still, the director of the reporting burn center at the time. In a later presentation, when queried about fluid requirements, he stated, "We were very impressed when we started using HBO. There was definitely less fluid loss, and the patients were drier. They appeared to heal earlier."
Interesting.
He mentioned they were investigating fluid requirements further. Later, Brannon and colleagues reportedly confirmed that these observations mentioned by Dr. Still were correct. Thus, the source concludes that while reported as a negative study in terms of primary endpoints, the Brannon paper actually had positive clinical observations in agreement with those of earlier investigators when its limitations and qualitative findings are considered.
That analysis certainly provides a very different perspective on that commonly cited study. The source also includes a specific clinical series on diabetic patients with foot burns, which are notoriously difficult to heal.
Yes, Jones and colleagues reported on a series of diabetic patients suffering foot burns. These are particularly challenging wounds due to underlying vascular disease and neuropathy. In this study, transcutaneous oxygen studies measuring oxygen levels in the skin were performed. Those patients who had low transcutaneous oxygen readings that responded to an oxygen challenge, indicating potentially salvageable tissue, underwent hyperbaric oxygen treatment in addition to standard wound care. There were 18 patients in this hyperbaric study group.
In the results.
Notably, according to the report, all 18 hyperbaric oxygen-treated patients healed their burns, with only one patient ultimately requiring an amputation.
All healed with only one amputation.
Yes. The control group consisted of 68 patients treated with traditional wound care alone. In this control group, 11 patients suffered a total of 31 amputations.
A stark contrast.
A very stark contrast. The authors reported the observations of their burn surgeons, who felt that, with a larger sample size, a definite statistical benefit could be demonstrated. A particularly notable clinical pearl from this series, highlighted by the source, is that 3 of the patients in the hyperbaric oxygen group, who were scheduled for grafting because their wounds weren't healing, instead healed spontaneously with hyperbaric oxygen alone, obviating the need for surgery.
Wow, avoided surgery completely.
A powerful anecdote supporting the potential for tissue salvage and accelerated healing.
Okay, time for an end-of-chapter mega recap on the clinical experience reported in the source.
Let's do it. The human data, spanning early serendipitous observations to numerous clinical series and controlled studies over 6 decades, consistently reports multiple observed or statistically significant benefits.
Including
Improved healing, decreased length of hospital stay, reduced mortality in larger series, decreased number of surgeries and grafting procedures, reduced fluid requirements, improved morbidity, and demonstrated cost savings.
specific studies like Hearts and News showed significant results.
Yes, Hart's sham control trial and New's large series reported statistically significant reductions in healing time and mortality, respectively. Studies by Cianci and colleagues detailed significant reductions in surgeries, length of stay cost, fluid requirements, edema, and weight gain during resuscitation.
And Niezgoda's study.
The Niezgoda study in human volunteers is highlighted as the first prospective randomized, double-blind human study to report statistically significant quantitative reductions in early wound hyperemia, size, and exudation.
The controversial Brannan study.
While often cited negatively, is presented with critical methodological limitations by the source and shown to have included important positive qualitative observations consistent with earlier findings, particularly regarding fluid management and healing.
And finally, the diabetic foot burn study.
Yes. The striking results from the diabetic foot burn series demonstrate impressive wound healing and amputation prevention with adjunctive hyperbaric oxygen in a challenging patient population, including specific cases of spontaneous healing that avoided planned grafting.
Okay, let's explore some of the more recent perspectives presented in the source, moving beyond the bulk of experimental and clinical data, starting with pain management, which was highlighted earlier as a significant ongoing challenge in burn care.
Pain is indeed a major issue. Acute pain, chronic pain, especially neuropathic pain. The source notes there is a substantial body of evidence reporting the use of hyperbaric oxygen in pain attenuation across various conditions. They reference a review by Sutherland and colleagues who concluded, based on their analysis, that hyperbaric oxygen has been proven to demonstrate a significant antinociceptive effect, meaning it helps reduce the sensation or intensity of pain.
How does this potential antinociceptive effect relate to the challenges we face in managing burn pain, like opioid use?
Well, a particularly difficult problem is managing pain effectively without excessive reliance on opioids. Opioid overuse is a major concern, and in burn patients specifically, it's been suggested high opioid doses may contribute to adaptive immune suppression, potentially leading to poorer outcomes like increased infection risk.
Yeah.
So the ability to effectively manage pain, including weaning patients from opioids or reducing their overall requirement, would be an important contribution.
And neuropathic pain specifically?
Neuropathic pain caused by nerve damage is typically difficult to treat with conventional analgesics and is thought to occur in a significant percentage of severe burn patients, impacting long-term quality of life. Hyperbaric oxygen's potential here is quite interesting.
What studies investigate this?
The source details several. Rasmussen and colleagues conducted a controlled study in human volunteers using a controlled first-degree burn model. One group got control treatment, another got hyperbaric oxygen at 2.4 atmospheres absolute. The chamber-treated patients demonstrated attenuation of secondary hyperalgesia that's increased sensitivity to pain in areas surrounding the injury, essentially showing an antinociceptive effect beyond the immediate burn site.
So it affects central pain processing.
That's what the authors concluded. They stated that post-burn hyperbaric oxygen has a potent antinociceptive effect that appears to work at a central desensitization level, suggesting it impacts pain processing in the brain or spinal cord, not just locally. They suggested this model could fuel future neurophysiologic studies on central effects.
What about animal models of neuropathic pain? Gibbons et al.
Gibbons and colleagues showed in an animal model that hyperbaric oxygen causes an anti-allodenic effect, reduction of pain, caused by a stimulus that doesn't normally cause pain, like light touch. They demonstrated this in rats with sciatic nerve crush-induced neuropathic pain. The reversal of this effect by N-terminal telepeptide suggests that brain opioid mechanisms might be involved in the relief of neuropathic pain induced by hyperbaric oxygen. This is presented as an important paper suggesting further research areas into specific pain pathways modulated by hyperbaric oxygen.
And ding it all.
More recently, Ding and colleagues demonstrated that early initiation of hyperbaric oxygen treatment in rats with neuropathic pain significantly alleviated hyperalgesia. They investigated the mechanisms and found that hyperbaric oxygen inhibited astrocyte expression, those support cells in the nervous system that can contribute to chronic pain and maintain normal synaptic structure in the spinal cord. In addition, inducible nitrox synthase and neuronal nitric oxide synthase, enzymes involved in nitric oxide production, which can be pro-inflammatory, were decreased in the dorsal horn of the spinal cord, a key area for pain processing. They also noted a decreased release of inflammatory factors, tumor necrosis, factor alpha, and interleukin beta.
So multiple potential mechanisms there?
Yes. Their conclusion was that hyperbaric oxygen significantly improves hyperalgesia in rats with neuropathic pain, and that these decreased expressions and levels are important mechanisms for how it alleviates neuropathic pain.
Chen et al.
Chen and colleagues, using an accepted burn injury model in rats, found that hyperbaric oxygen at 2.5 atmospheres absolute reduced burn-induced neural apoptosis, or programmed cell death, in the ventral horn of the spinal cord, possibly through signaling involving hypoxia-inducible factor 1 alpha. Preventing neural cell death could contribute to better long-term outcomes, including pain.
And Thompson et al.
Thompson and colleagues studied neuropathic pain following surgical manipulations resulting in mechanical hypersensitivity in a rat model. Animals got 90-minute treatments, 5 days a week for 2 weeks. The results indicated significant improvements over the 2-week period. Treated animals recovered more quickly and maintained recovery throughout the post-treatment period, demonstrating that hyperbaric oxygen is successful in alleviating neuropathic pain in this model.
So quite a bit of evidence on pain.
Yes. The force emphasizes that these studies represent a major step forward in understanding how hyperbaric oxygen may provide pain relief in burn patients and are worthy of further exploration, especially since pain relief is a stated community goal and neuropathic pain remains difficult.
The source also briefly revisits immunity and infection in this recent perspectives section. Any new insights?
Yes, they reiterate the major problem of the innate inflammatory response, increased neutrophils macrophages, downregulated T-cell responses. Zhang and colleagues are cited for showing that hyperbaric oxygen attenuates apoptosis and decreases inflammation in an ischemic wound model, suggesting it can reduce tissue damage and inflammation concurrently. The effect on modulating white cell adherence to endothelium discussed earlier is recalled as relevant. Tom and colleagues specifically studied the effect on platelets and endothelial adhesion, demonstrating that hyperbaric oxygen doesn't alter platelet function, but does inhibit beta-2 integrin adhesion to endothelium at pressures of 2.8 atmospheres absolute or more.
Inhibiting white cell sticking.
Exactly. Integrin adhesion is how white cells stick to blood vessels. The source suggests this inhibitory effect would benefit early burn injury stages by reducing inflammatory cells damaging the microvasculature.
And regarding the stem cell findings in recent perspectives.
The source reiterates Chomet's compelling findings. Hyperbaric oxygen increases marrow stem cell populations by 800%, and these cells migrate to wounds. They also reiterate the potential for preserved dermal elements, like hair follicles, to recruit native stem cells within the wound, complementing circulating ones. The current interest in stem cell therapy for prolonged burn healing and the promise of further research here, especially how hyperbaric oxygen interfaces, are reiterated.
Finally, the source addresses potential antioxidant effects and the concern about oxygen toxicity.
Concern about oxygen toxicity, particularly pulmonary, is acknowledged as valid. However, Sharada and colleagues are cited for a study in chronic wounds, reporting that hyperbaric oxygen exposure actually enhanced plasma antioxidant defenses, the body's natural defense against oxidative stress, and it contributed to healing resolution, angiogenesis, new blood vessel formation, and vascular tone regulation. By increasing vascular endothelial growth factor, VEGF, and suppressing inflammatory cytokines and signaling interleukins. This suggests that while oxygen is pro-oxidant, hyperbaric oxygen can trigger beneficial antioxidant and anti-inflammatory responses in the context of healing. The source notes that acute oxygen toxicity, like seizures or acute lung injury, is very rare in clinical practice when using hyperbaric oxygen for burns with appropriate protocols. It's usually associated with the much longer treatments used for things like decompression sickness.
Okay, let's do an end-of-chapter mega recap on recent perspectives.
All right. Recent research highlights hyperbaric oxygen's significant potential in pain management, showing anti-nociceptive and anti-allodynic effects in human and animal studies. Proposed mechanisms involve central nervous system effects, potential opioid pathways, and reduction of key inflammatory mediators in spinal pain centers.
It also reinforces benefits on immunity and inflammation.
Yes, showing attenuated apoptosis, decreased inflammation, and importantly, inhibition of white cell adhesion to blood vessels.
And stem cells.
Further work confirms the impressive stem cell mobilizing effects, that 800% increase in marrow stem cells, migration to wounds, potentially contributing to preserving dermal elements and aligning with interest in stem cell therapy.
Antioxidant effects.
Studies indicate hyperbaric oxygen enhances the body's antioxidant defenses and promotes healing and angiogenesis via VEGF and cytokine suppression, while the risk of acute oxygen toxicity in clinical burn treatment is considered very low with standard protocols.
Let's shift focus now from the research evidence and mechanisms to the practical aspects of clinical management presented in the source, starting with surgical perspectives and how adjunctive hyperbaric oxygen fits into the modern surgical approach to burns.
Okay. Over the past 50 years, there's been a significant swing towards more aggressive surgical approaches, early tangential or sequential excision and grafting of deep second-degree and probable third-degree burns, especially on functionally important areas like hands, joints, face. The goal is early removal of non-viable tissue.
Given that aggressive surgical approach, how does adjunctive hyperbaric oxygen therapy find its place? Is it an alternative or a complementary therapy?
The source positions it not as an alternative, but as another modality available to the surgeon to improve outcomes. It's particularly useful for managing deep second-degree burns, or burns where surgical excision might be imprecise or difficult, or where preserving tissue is paramount. Think about areas where surgical technique can be imprecise, or where coverage with grafts is sometimes difficult for optimal function, or cosmetics, hands, fingers, face, ears, other complex anatomical regions. For these less defined, deep partial thickness wounds, which might not be obviously full thickness but are deeper than superficial, and where the surgeon is hoping to salvage tissue, the suggested approach involves treating them with topical antimicrobial agents, bedside and enzymatic debridement, wound care including biological dressings, and adjunctive hyperbaric oxygen. The force explains that this combined approach allows the surgeon more time for spontaneous healing to take place in the zone of stasis and for better clinical definition of the precise extent and depth of the injury before making a definitive decision to excise and graft.
So it can potentially reduce the need for surgery.
Potentially yes in some cases, or reduce the size of the area needing grafting. The source includes several figures illustrating patient outcomes with this approach. Figure 16 shows a young woman with significant facial burns. You see dramatic edema resolution after just 2 hyperbaric oxygen treatments, continued healing, and ultimately an impressive long-term outcome reportedly achieved without grafting. Figure 17 shows a man with a massive 70% TBSA burn, striking edema reduction early on, and importantly, no skin grafts needed on the chest and torso after 30 days, suggesting preservation of deeper dermal layers. Figure 18 shows a deep hand burn healing without grafting, preserving function and flexibility, even showing preserved hair follicles. Figure 19 shows an ear burn with exposed cartilage that epithelialized over 18 days. Figure 20 shows another severely burned hand needing fasciotomy but ultimately healing without grafting, with full function and flexibility. And Figure 21 illustrates recovery from a high-voltage electrical burn over several months. These figures serve as vivid examples from the source of outcomes reportedly observed, particularly regarding tissue salvage and healing in challenging burns.
So the source claims it reduces healing time.
Yes, the source states that adjunctive hyperbaric oxygen has drastically reduced the healing time in major burn injury, especially if the wounds are deep second degree, those most amenable to tissue salvage. They also mention a theoretical benefit for less well-defined third-degree burns.
What about fourth-degree burns, often from electrical injury?
For fourth-degree burns involving muscle or deeper tissues, common in high-voltage electrical injuries, hyperbaric oxygen is presented as beneficial due to a reported reduction in fascial compartment pressures.
How?
Injured muscle swelling is lessened by the preservation of aerobic glycolysis, maintaining cellular energy. Later, it's also beneficial by reducing anaerobic infection, which is a significant risk in devitalized deep muscle tissue. Figure 21, the electrical burn, is relevant here.
And it helps with reconstruction. Flaps and grafts.
Yes. The source notes that complex reconstruction using flaps, full-thickness grafts, and composite grafts has been greatly facilitated by adjunctive hyperbaric oxygen. The decision to use it is often made intraoperatively during surgery when a surgeon is concerned about the viability of a compromised flap or a challenging graft. Patients are often even prepared preoperatively for the possibility of receiving adjunctive hyperbaric oxygen immediately postoperatively if compromise is a concern, integrating it directly into the surgical plan.
The source also provides some recent clinical experience beyond what we discussed earlier, Chang et al. From Taiwan.
Yes, an important recent paper reporting on patients burned in a massive explosion at a theme park, real-world data from a mass casualty incident. The hyperbaric oxygen-treated group reportedly had a higher survival rate of skin grafts and a significant reduction in procalcitonin levels, consistent with less infection. While there was no significant change in hospital days observed, the source attributes this potentially to local laws and hospital policies in Taiwan, influencing discharge timing independently of wound healing speed.
And Oli and colleagues, that was randomized.
Yes, Oli and colleagues recently reported a case-controlled randomized human study. They noted significantly reduced wound complications, P0.006, and significantly reduced length of hospital stay, P0.001, in the hyperbaric oxygen group. They also detailed findings regarding inflammatory markers related to white cell adhesion. Hyperbaric oxygen significantly reduced the expression of intracellular adhesion molecule 1 messenger RNA, P0.05, and also significantly reduced intracellular adhesion molecule 1 serum level, P0.004.
ICAM-1 again.
Yes, involved in white blood cells sticking to blood vessel walls, a key step in inflammation. The authors concluded that hyperbaric oxygen can effectively reduce thermal wound complications and length of stay. They also reported interesting correlations. The number of hyperbaric oxygen sessions strongly correlated with the ICAM-1 serum levels, P0.043, but poorly with ICAM-1 mRNA gene expression, P0.22. However, gene expression strongly correlated with the serum level, RCare.988 P001. This data supports the mechanism of reduced white cell adhesion being clinically relevant and responsive to hyperbaric oxygen.
And Jensen et al. On biofilm.
Finally, Jensen and colleagues demonstrated experimentally the ability of hyperbaric oxygen to penetrate biofilm, those protective bacterial communities, thus potentially enhancing white cell killing and antibiotic effectiveness within infected wounds. They also commented on the direct bactericidal effect of hyperbaric oxygen itself at appropriate tissue oxygen tensions.
What are the practical considerations for providing hyperbaric oxygen therapy safely and effectively in a burn center setting? Staffing, expertise.
Units planning to treat burn patients with hyperbaric oxygen should be experienced in managing critical care patients in the hyperbaric setting and be familiar with the specific complex problems of burn patients before initiating a program. Preferably, personnel involved should be certified in both burn care and hyperbaric oxygen therapy. The hyperbaric department should function as an extension of the burn unit, working closely with the burn team in a multidisciplinary approach.
When should therapy ideally be initiated, and what's a typical treatment regimen?
Treatment is recommended by the source to be begun as soon as possible after injury, often during initial resuscitation, to impact those early dynamic changes. Treatments are attempted 3 times within the first 24 hours if possible, provided the patient is stable enough, and then continued twice daily thereafter. A typical regimen involves 90 minutes of 100% oxygen delivery at a pressure of 2.0 to 2.4 atmospheres absolute. This 90 minutes is at depth plus descent and ascent time as the patient tolerates. Early experience in treating children sometimes use shorter 45-minute sessions, but more recent extensive use shows adult protocols are safe and effective in pediatric burn patients.
What about monitoring and supporting critically ill burn patients inside the chamber? Ventilators? Fluids?
Patients must be continuously monitored, just like in the ICU. Blood pressure can be monitored via transducers or non-invasively with tested cuffs. Critically, patients can absolutely be maintained on mechanical ventilator support during treatment, which is frequent in larger burns with inhalation injury.
And carbon monoxide poisoning.
Right. Many burn patients also suffer concurrent carbon monoxide poisoning. The source cites Radford's 1974 study where 80% of fire scene deaths had carboxyhemoglobin levels over 20%. A National Academy of Sciences conference recommended treating all unconscious or obtunded fire patients empirically for acute carbon monoxide poisoning with hyperbaric oxygen, unless unnecessary. The benefit for carbon monoxide poisoning is well established. Figure 2 shows a table detailing causes of death at fire scenes, highlighting the significant prevalence of carbon monoxide.
Fluid management sounds particularly tricky in the hyperbaric setting.
It is mandatory and requires careful attention. Initial fluid requirements can be several liters per hour. Pumps, capable of delivering fluid at pressure, must be used inside the chamber. Adequate resuscitation in the first 24 hours can be problematic. The source notes certain patients can develop hypotension after exiting the chamber. Careful volume replacement and assessment are mandatory before, during, and after treatment. They specifically suggest increasing fluids during ascent may help compensate for any hypovolemia unmasked after exposure. Burn surgeons should order specific fluid regimens during treatment.
Temperature control.
Fever. Maintaining a comfortable ambient temperature is important. Thermal instability can be a problem after wound cleansing, especially in large burns. Patients should be assessed prior to exposure. Febrile patients must be monitored closely and fever controlled, as oxygen toxicity, while rare, is reportedly more common in febrile individuals.
How long do patients typically receive treatments? Is there a set number?
Duration isn't rigidly fixed. It depends on clinical progress and goals, continuing as the burn surgeon requests. In large burns, 40% TBSA or greater, it should generally be given for 10 to 14 days in close consultation with the surgeon, aiming for early benefits. Many partial thickness burns will heal without surgery during this time. Treatment beyond 20-30 sessions is usually for optimizing graft take. It's rare to exceed 40-50 sessions, and utilization review is recommended after 30 sessions in a case-by-case basis.
What about topical agents? Sulfamylon.
The source addresses a historical concern about mafenate acetate, sulfamylon. Removal was recommended prior to hyperbaric oxygen due to potential carbon dioxide buildup. The source notes sulfamylon is less frequently used now. They state their limited use hasn't resulted in observed issues. Silver sulfetazine is noted as the most widely used topical, generally compatible.
Chamber type. Transport.
Patients can be treated in multiplace or monoplace chambers. Movement over long distances isn't recommended. The chamber should ideally be within the same facility as the burn center.
Based on all this, who are the ideal candidates for adjunctive hyperbaric oxygen therapy in burn care, according to the source? Patient selection criteria.
The source recommends it for serious burns. 20% or greater total body surface area and involvement of hands, face, feet, or perineum, if deep, partial, or full thickness. These are areas where preserving function and minimizing scarring are particularly important.
But the surgeon decides.
Yes, the decision to treat more superficial burns, or any burn, is always at the discretion of the burn surgeon managing the patient. It's an adjunctive therapy. Importantly, patients with severe burns deemed not expected to survive despite maximal therapy should not be treated with hyperbaric oxygen. It's not life support for non-survivable injuries. They specifically mention flash burns to the face, often painful, should be considered, noting rapid pain control reported from personal experience. Ultimately, the decision rests with the burn surgeon.
Regarding utilization review for extended treatments.
Yes, as noted, utilization review is simply recommended after 30 sessions to evaluate ongoing need.
We touched on the extraordinary cost of burn care earlier. Does the source provide more specific data on the cost impact related to using adjunctive hyperbaric oxygen?
Burn care is extremely expensive. The source reiterates costs from the 2022 National Burn Repository. Survivors of 60% TBSA burns average $1,628,632 USD to 2023 for the hospital stay alone.
Over 1.6 million.
Just for the stay. Additional costs or time, surgical fees, artificial skin, rehab can add another $799,875 USD or more for burns over 80% TBSA. It's immense.
And the cost of the hyperbaric therapy itself?
The source provides data from 2008 from a Northern California burn center. Hyperbaric oxygen therapy hospital treatment costs averaged approximately $21,000 in 2023 USD per patient. Compared to the total cost, it seems relatively small.
So the argument is about cost savings.
Yes. While not always explicitly calculated, the source argues cost savings are implied in all clinical studies reported that showed reductions in healing time, length of stay, and number of surgeries grafting. 6 of these studies specifically analyzed costs, estimating a range of average savings in patients treated with hyperbaric oxygen from $95,430 USD to $150,688 USD per case.
But significantly higher than the cost of the therapy itself.
Yes, suggesting a favorable cost-benefit ratio. The source notes corroboration from a recently published randomized study from Turkey. This study showed hyperbaric oxygen added to conventional treatment for deep second-degree burns had a significant positive effect on outcomes and reduced treatment cost. Specifically, more rapid epithelialization, PI 0.001, reduced need for surgery, P 0.0003, and reduced need for grafting, P 0.03. This recent randomized report agrees with all the aforementioned clinical studies quoted in the chapter, reinforcing evidence for both clinical benefit and cost effectiveness.
Okay, time for the end of chapter mega recap on clinical management and cost.
Right. Adjunctive hyperbaric oxygen is presented as a valuable modality for burn surgeons, particularly for deep second-degree burns or those in challenging areas like the face or hands. It potentially allows salvage of tissue, delaying or reducing the need for surgery, promoting spontaneous healing, and facilitating reconstruction.
Recent trials support its use.
Yes, showing improved graft survival, fewer infection markers, significantly reduced wound complications and length of stay associated with decreased ICAM-1. It also helps penetrate biofilm and enhances white cell killing.
Provision requires
A dedicated team with critical care expertise, a multidisciplinary approach, initiating treatment early. 2.0, 2.4 atmospheres absolute. Careful monitoring and fluid management are essential.
duration, selection.
Duration varies, typically 10-14 days for large burns, extending for graft optimization, with utilization review after 30 sessions. Selection criteria focus on serious burns and functional areas, with the burn surgeon making the final decision.
And the bottom line on cost.
While burn care is extremely expensive, specific hyperbaric oxygen costs are relatively low. Multiple studies estimate substantial cost savings per case, roughly $95,000 to over $150,000 USD, due to reductions in length of stay, surgeries, and grafting, corroborated by recent randomized data.
The source also discusses meta-analyses and systematic reviews that have attempted to synthesize the evidence regarding hyperbaric oxygen in burns, highlighting different conclusions reached by these reviews.
Yes, they address these broader evidence reviews. They discuss the review by Small and colleagues, presented as arguably the best review, identifying 47 publications meeting PRISMA guidelines. Small and colleagues concluded that hyperbaric oxygen unquestionably have a positive impact on the pathophysiological mechanisms and hence on the healing and course of burns.
Unquestionably positive.
That was their conclusion. They explained the few negative results seen are likely due to peculiarities in administration or interactions in severely ill patients. The source states this comprehensive review supports their assertion of ample evidence for efficacy and safety, though more information is always helpful. They also discuss Whitegasser and colleagues' recent publication strongly recommending adjunctive hyperbaric oxygen for thermal burns, noting it's supported by an acceptable level of evidence.
Why acceptable level? What about randomized trials?
The source explains the grading basis. Thermal injuries are inherently heterogeneous, making perfect, large, homogeneous, randomized controlled trials very difficult. Therefore, the European Consensus Conference on Hyperbaric Medicine Grading, acknowledging these difficulties, supports the use recommendation, indicating recognized support within the field despite challenges of traditional study design.
Let's talk in detail about the 2009 Cochrane Review by Villanueva and colleagues. The source dedicates significant discussion to this review and presents a critical perspective.
Yes, this is a key review often cited, and the source provides a detailed critique. The 2009 Cochrane Review identified 4 randomized controlled studies, but only 2 satisfied their strict inclusion criteria. The Hart study, 74, and the Brannan study, 97. The Cochrane group felt heterogeneity between these 2 prevented pooling for meta-analysis.
What did Cochrane say about the Hart study?
Regarding the Hart study, which reported significantly shorter mean healing time, 19.7 versus 43.8 days, Peter 0.001, the Cochrane authors suggested it was constrained by a lack of statistical power to detect useful clinical differences.
But it had a p-value less than 0.001.
Exactly. The source counters that suggesting insufficient power seems to contradict the study's own reported highly statistically significant p-value.
And the Brannan study?
Regarding the Brannan study, which reported no significant difference in mortality, length of stay, or surgeries, the source reiterates their view that it was significantly constrained by multiple limitations we discussed earlier: delayed treatment, limited outcome studied, confounding factors, heterogeneity, and aggressive standard care potentially masking benefits.
So what was the Cochrane conclusion?
The source quotes the Cochrane author's concluding statement. While there are promising results from non-random clinical reports, there is insufficient evidence from randomized controlled trials to recommend or refute the routine use of hyperbaric oxygen for the treatment of thermal burns.
The source has a strong reaction to that conclusion.
Yes, stating this conclusion has been misinterpreted and used to deny uncounted patients this valuable therapy, implying the lack of a strong recommendation against it has been incorrectly taken as a recommendation not to use it, despite other evidence. The Cochrane authors suggested large multi-center randomized studies are needed.
But the source explains why that's difficult.
Exactly. Exceedingly difficult and expensive without significant funding. The vast percentage of burns treated are smaller. Only 4% of admissions are 40% TBSA nationally. This necessitates a multi-center format, which is hard to fund and coordinate. Attempts have proven difficult. The source specifically notes the Cochrane report did not consider several outcome studies with matched controls. The large clinical series we discussed showing reduced length of stay, fluid requirements, surgery, and cost-effectiveness, because they weren't randomized controlled trials meeting strict criteria.
So they value other evidence, too.
Yes, they offer a counterpoint. While outcome reports have limitations, they represent valid analyses of benefits and underscore that the observations of skilled and experienced physicians remain an important component of determining therapeutic efficacy, especially when rigorous randomized trials are logistically challenging.
So the ideal trial is desirable, but maybe not feasible soon?
Correct. They conclude a well-designed, randomized, blinded control study with sham treatment is desirable, but remains to be performed due to logistical difficulties. They briefly mention a funded Army study protocol that was abruptly canceled without explanation, highlighting the challenges.
Okay, end of chapter mega recap on meta-analyses and reviews.
All right. While some comprehensive reviews, Small, White-Gasser, and the European Consensus Grade support adjunctive hyperbaric oxygen based on existing experimental, clinical, and pathophysiological evidence.
The 2009 Cochrane Review concluded insufficient randomized controlled trial evidence to recommend or refute routine use based on only 2 studies they deemed includable but heterogeneous.
Yes. The source strongly criticizes Cochrane's exclusion criteria and interpretation, especially regarding the Brandon study's limitations, and highlights the huge logistical and financial hurdles for the ideal large multi-center randomized controlled trial Cochrane suggested.
They counterbalance this by emphasizing the value and validity of consistent, positive observations from numerous clinical series and experienced physicians over decades, especially when high-level randomized evidence is hard to obtain in complex fields like burn care.
Precisely.
Let's synthesize all this information presented in the source in the discussion section, putting it into the broader context of burn care advancements and where adjunctive hyperbaric oxygen might fit.
Okay. Since the mid-1980s, we've seen significant advancements: early excision, nutrition, ventilation, infection control. However, the source points out that despite these, there appears to have been little change in overall mortality rates since then, except perhaps some improvements in older patients with larger burns.
Early excision helped, but maybe hit a limit.
It seems so. Early excision decreased mortality and length of stay primarily in smaller burns and those without inhalation injury. Ingrav's review of 35 years at Harborview reported early excision didn't significantly decrease length of stay for larger burns, with little change since 1990. This led some experts to suggest burn care may have achieved a floor of survival.
Meaning further progress is hard with current standard care alone.
Potentially, yes, for the most severe injuries. The source argues strongly that further significant improvement in mortality, length of stay, and cost containment must come from additional therapeutic developments. They reiterate that adjunctive hyperbaric oxygen, used as a complement, has been shown in numerous reports to reduce length of stay and cost in conjunction with early excision and comprehensive management. They refer readers to a recent review on burn research priorities.
There's a figure summarizing the systemic effects of burns.
Yes, Figure 23, Systemic Effects of Major Burns. It's a detailed diagram illustrating the complex multi-system challenges: cardiovascular, hypovolemia, myocardial depression, shock; vascular, capillary leak, massive edema; respiratory, airway injury, ARDS; peripheral splanchnic vasoconstriction leading to SIRS and gut issues; hormonal activation, HPA, SNS, RAA; hypercoagulability, hypoalbuminemia, the prolonged hypermetabolic phase; catabolism, weight loss, muscle wasting; hyperdynamic circulation, hypothermia, immunosuppression; impaired healing, acute kidney injury, ileus, GI stress ulcers, and the challenges of fluid resuscitation itself, leading to more edema and compartment syndromes. It's incredibly complex.
And the source's key takeaway regarding hyperbaric oxygen in this figure.
Crucially, the source emphasizes as a concluding point that adjunctive hyperbaric oxygen, through the various mechanisms and clinical effects we've discussed impacting edema, microcirculation, inflammation, infection, metabolism, reperfusion, stem cells, tissue repair, has been shown to favorably address virtually all these therapeutic challenges noted in that comprehensive illustration.
So not just treating the wound, but modulating the whole systemic response.
Exactly. positioning it as a modality that can broadly modulate the profound and damaging systemic response to injury, which drives so much the morbidity and mortality.
That diagram and the stated ability of hyperbaric oxygen to impact so many of those systemic issues is a powerful way to synthesize the potential benefits. Let's pull all of this together in the final comprehensive summary presented in the source.
Okay, the summary reiterates that hyperbaric oxygen's benefit in burns has been demonstrated in numerous animal studies and human reports over 6 decades, a significant body of evidence. The observed benefits consistently reported include modulation of burn shock, dampening inflammatory response, reduction of edema, reversal of zone of stasis progression, reduction of ischemia and necrosis, prevention of partial to full thickness conversion, modulation of inflammation affecting hypermetabolic syndrome, lessening capillary leak, preservation of dermal elements, reduced need for grafting, shortened hospital stay, reduced post-discharge problems, and reduced cost of care.
The source acknowledges the need for improvement in burn care.
Yes, acknowledging the burn community's awareness of the need for improvement in pain control, speed of healing, and scarring. Wolf and Ungrav are referenced again regarding limited progress in the last 20 years, especially controlling inflammation, hypermetabolism, infection, and scarring.
Given this need and the demonstrated effects, what is the source's main assertion or call to action?
The source makes a strong assertion. It is time for the burn community to routinely consider hyperbaric oxygen in the treatment of clinical burns, given the highly significant body of research that addresses these problems directly. They describe their reluctance as puzzling in light of overwhelming positive reports. They suggest this might be due to insistence by some on a multi-center, double-blind, randomized study of sufficient power as the only acceptable evidence, which they believe is unlikely soon due to cost and logistics.
They mention military experience.
Yes, noting the experience with military burn casualties and stating it's incumbent on the military to utilize all effective modalities, suggesting hyperbaric oxygen is one. They reiterate that current data shows hyperbaric oxygen, as an adjunct, is cost-effective, improves morbidity mortality, reduces length of stay, and lessens surgery need. Its safety is reiterated in trained hands with appropriate monitoring and selection.
They come back to figure 23.
Yes, highlighting again the difficulty of dealing with the complex challenges illustrated in Figure 23 and reinforcing the key point that adjunctive hyperbaric oxygen favorably addresses virtually all these challenges.
There's a quote from Dr. Boykin.
Yes, a powerful 2013 quote from J.V. Boykin, MD. He states, "It is clear from review of collected research and clinical data that hyperbaric oxygen provides a unique environment for wound recovery and tissue regeneration for thermal injury that cannot be comparably achieved by our current surgical and medical therapies."
A unique environment.
He notes observed reductions in morbidity and length of stay from structured programs, the firm biological physiologic basis built over 3 decades, especially regarding stem progenitor cell signaling. His final point quoted is that research suggests this therapy has potential to provide a much-needed elevation of the floor of survival for burn victims and should provide substantial enhancements in wound healing and quality of life.
So the desire for more trials remains, but...
Yes, the desire for additional clinical evidence from a well-designed, multi-center randomized study is reiterated, but countered again. While awaiting more data, observations of seasoned clinicians remain a valid test of efficacy, especially when trials are difficult. Given the unique beneficial effects shown, formal integration of hyperbaric oxygen in early burn management should be thoughtfully considered and further investigated.
The source concludes with a direct question.
Yes, the studies reviewed have demonstrated the efficacy. The question is therefore not why adjunctive hyperbaric oxygen should be utilized, but rather why patients are not provided the benefit of this treatment when there is overwhelming experimental and clinical data to support it. They also quote Mark Yeshket et al. From Primer, Burn Injury. Although we have made some important strides, burn care needs to change, new technologies need to be adopted to further improve burn outcomes.
Positioning hyperbaric oxygen as one such technology.
Exactly.
To ensure we cover all the practical details for clinicians considering this therapy, let's walk through the specific summary of treatment guidelines provided in the source.
Okay, these provide a practical framework. First, the patient should be referred by the burn surgeon. It's adjunctive therapy based on surgical assessment.
What are the specific indications recommended?
Indication is for serious burns. 20% or greater TBSA and/or involvement of hands, face, feet, or perineum if deep, partial, or full thickness. These are key functional cosmetic areas. However, the decision to treat more superficial burns or any burn is always ultimately at the burn surgeon's discretion. Before starting, do a thorough assessment for fitness to tolerate treatment and check for contraindications like untreated pneumothorax. Patients should be stable and accepting. Ensure critical care staffing is available in the hyperbaric unit.
Recommended treatment regimen: pressure, duration, frequency.
Treat at 2.0 or 2.4 atmospheres absolute for 90 minutes at depth, plus disintention time as tolerated. Monitor closely throughout. Frequency. Attempt 3 treatments in the first 24 hours if possible, then twice daily thereafter. Daily dialogue with the surgeon and wound inspection are recommended.
Duration. Grafting.
Duration continues as surgeon requests based on response. For grafting, provide 1 to 2 treatments pre-op at 2.0 or 2.4 atmospheres absolute. Post-grafting, twice daily until graft take, usually 3 to 5 days. Overall duration, usually 10-14 days for large burns, 0.4-40% TBSA. Many partial thickness burns heal without surgery in this time. Rare to exceed 40 treatments, but not contraindicated case by case. Utilization review recommended after 30 sessions.
Careful fluid management is noted as particularly crucial.
Yes, mandatory. Monitor carefully. Hypovolemia can be masked by pressure. Additional fluids may be needed during after decompression. Be prepared to give fluids ordered by the surgeon during treatment.
Temperature, topicals, transport.
Maintain comfortable ambient temperature. Assess thermal stability pre-treatment, especially large TBSA. Control fever. Regarding topicals, historical concern about sulfinolone, less used now. Silver sulfadezine, more common, generally compatible. Chamber can be multi-place or monoplace. Transport over long distance is not recommended. Chamber should be in the same facility.
Finally, the source lists some specific caveats or important considerations.
Yes. First, reiterate. Be prepared to provide fluids during treatment. Second, maintain critical care standards. Third, otic barotrauma may be a problem in larger TBSA head neck burns. Pay careful attention. Use early ENT consult if needed. The author's unit was equipped for on-site myringotomy intubation to prevent delays.
Okay, we've covered an incredible amount of ground drawn entirely from this specific source chapter. We've looked at the challenging statistics, complex pathophysiology, decades of experimental data, human clinical experience, proposed mechanisms like reperfusion and stem cells, practical management, economic impacts, and debates around evidence and guidelines.
That's right. We've seen how the source presents a comprehensive case. Hyperbaric oxygen reportedly modulates burn shock, reduces inflammation edema, preserves tissue, reduces surgery grafting need, shortens stay, saves costs, potentially addresses infection and pain, and maybe influences long-term outcomes. The argument is it impacts virtually all systemic effects.
And is presented as being safe when administered by trained personnel in a critical care setting with careful selection and monitoring.
Absolutely. While acknowledging the call for definitive randomized controlled trials, the source balances this by highlighting consistent positive findings across vast research over decades and underscores the validity of experienced clinical observation, especially when large trials are challenging.
Here's where it gets really interesting, and perhaps a provocative thought for you, the specialist clinician listener, to consider based on everything we've unpacked from the source material today. Given the substantial experimental and clinical evidence base presented in this chapter, detailing numerous proposed multi-system benefits from cellular mechanisms up to significant reported impacts on patient morbidity, mortality, length of stay, and cost. What do you believe are the primary barriers preventing wider, more integrated adoption of adjunctive hyperbaric oxygen in mainstream burn centers today, if the evidence is truly as overwhelming and supportive as this source suggests? And how might these barriers, whether cost, access, perceived lack of gold standard evidence, or something else, be effectively addressed by the burn and hyperbaric medicine communities working together?
A critical question for the field to grapple with as we seek to improve outcomes for these complex injuries.
Indeed. And that's the deep dive for today.